blood sugar is very important. In this 7 years intensive insulin therapy in 62 patients with type 1 diabetes, there was a standardization of PMD and decreased bone resorption marker and PTH. And this is the result of that study. So here, no diabetes, adequately controlled diabetes, and inadequately controlled diabetes where there is increased porosity again. Anti-diabetic medication, again, this is from ADA. Clinicians should consider a potential adverse impact on bone health, selecting pharmacological option. To reduce the risk of fall and fracture, glycemic management goals should be individualized for people with diabetes. And these are the effect of different anti-diabetic agents on bone, and metformin, an example, is maybe there's decrease in fracture risk, but thiazolidine diones, there is an increase of fracture risk and an increase in insulin because of falls mainly and hypoglycemia. Physical activity is very important, and individualized intervention to prevent falls, maintain mobility, and delay disability are important. Calcium and vitamin D, so calcium intake based on a specific recommendation, and vitamin D better to optimize more than 30. And this is again from ADA guidelines, advise people with diabetes on their intake of calcium and vitamin D to ensure it meets the recommendation daily allowance. Anti-resorptive medication and anabolic agents. Here, you start, of course, therapy with T-score less than -2, as I said, but there is, in general, there is no difference in management of the patient with type 2 diabetes or with diabetes and with no diabetes when it comes to selection of anti-fractures. Okay, so the sub-analysis of freedom study in patients with DM showed denosumab effective in decreasing vertebral rather than non-vertebral fracture, but also denosumab may improve insulin resistance and FPS, so it has advantage. Teriparatide was found to be effective in patients with type 2 diabetes. This is the anti-sclerostin romosozumab. So romosozumab, it inhibits sclerostin, so it may be helpful in patients with type 2 diabetes. I said this is part of pathophysiology. But we have to take care that romosozumab associated with increased risk of myocardial infarction and stroke. So limiting its use in people with diabetes at higher risk for cardiovascular complications. I will not go through this one because it will take time. I will conclude that mineral bone density complication of DM are common. Several mechanisms are involved. Type 2 diabetes patients present mainly with altered bone quality. Diagnosis and the fracture assessment should take the altered bone quality in consideration, and drug therapy is similar to patients without diabetes. And thank you very much.
Thank you very much, Professor Abdul Mohsen. That was a very interesting lecture, I would say. And as a non-endocrinologist, I learned a lot.
Thank you.
In the interest of time, we'll just take one question and move ahead. If there's any question, very short question, please ask. Otherwise, we will move to the next speaker. Dr. Ghazi, I think he has a question.
Oh, thank you very much.
Yeah, please go ahead, Dr. Ghazi.
Excellent presentation and a subject which is new to many people. I just want to emphasize that usually osteoporosis occur in an elderly patient and also in 10 patients more than the obese patient, what you expect. And the question that it seems to be, these changes is irreversible, as you suggest, Do you have an idea about osteoclast? We know that osteoclast activity increase, okay? And senseless cell increase also in osteoporosis. Can you try to give us an education on this?
Yeah, definitely. Thank you very much. There is an increase in osteoclast activity, and there is also the problem that there is apoptosis of osteoblast and decreased proliferation for osteoblast. So not only increase osteoclast, but decrease also osteoblast. And also, in addition, we shouldn't forget the problem of bone quality because of increased adipocyte formation in patients with type 2 diabetes.
Okay, thank you for
Thank you.
Professor. I just encourage the attendees and to type their question in the QI answers. Then speakers can answer also at the end. Well, it's a very interesting topic, and I hope that the focus on the fractures in diabetes will take more studies and even more care from the professionals. And of course, the reference is with us, very near to us, Professor Abdel Mohsen. We will try to contact you for whatever is, we will do some cooperation in that prospect. Thank you, Professor.
Sure. Thank you very much.
Thank you, Professor, once again for the very interesting lecture. And let's move on to the next speaker. It's my pleasure again to introduce the next speaker, Dr. Ahmad Al-Ashri, who is an experienced specialist in the field of general surgery with more than 8 years of experience, with a demonstrated history of working in the medical practice industry, skilled in patient-centered customer service, medical education, medicine and emergency surgery and trauma, laparoscopic surgery, breast oncoplasty surgery, strong professional with a master's degree of surgery focused in general surgery from Alexandria University. And he's going to talk on the diabetic foot ulcer prevention, importance of screening and increasing patient awareness. Welcome, Dr. Ahmed. And the virtual screen is yours. Please start to share your screen. And whenever you're ready, please go ahead. Thank you. Dr. Ahmed, can you please share your screen? Yes, you're good to go. Please go ahead. Thank you. You are not audible. Cannot hear you yet, Dr. Ahmed.
Yes, good morning.
Yeah. Yes, no, yes. Good morning.
Good morning, doctor.
Please go ahead.
Okay. Okay. Yeah. Okay, good morning, everyone. It's a pleasure to be with you today. Today we're going to talk about one of the important issues, the diabetic foot and the diabetic foot problem. Okay, we'll start. We are going to mainly focus today a little introduction about the diabetic foot ulcers, and we're going to talk mostly about the prevention and the screening program. To start is, what is diabetic foot ulcer? There have been many definitions over the years, but it was summarized by the WHO as that it's any ulceration or any affection on the foot starting from the ankle going distally, and that is associated with neuropathy or different grades of ischemia and infection. This is how does the ulcer develop? The ulcer usually develop starting with the neuropathy, the peripheral sensory neuropathy, the motor neuropathy, the autonomic neuropathy, all of these leading to deformities and remodeling of the shape structure of the foot structure, leading to increased stress on certain areas. Also, this is also associated with peripheral arterial disease, leading to vasculopathies and ischemia and necrosis. This is simple diagram to show how it develops. Usually, the dryness and the pressure manifestation on the foot start developing callus formation. These callus with repeated pressure and stress start to cause an ulcer underneath, which by time start to get infected and an ulcer develops. Many classifications have been introduced through the years. All of them focus mainly on the local pathology and fail to assess the parameters related to the wound healing. There are many classifications being used: the University of Texas, the Wagner classification, SAT score, SINBAD, PIDA score. Wagner classification is the easiest one. It's 5 stages, starting from 0 to 5. It mainly describes the wound, the size, and the depth of the wound. The University of Texas classification is more thorough as it introduces with the ischemia and the infection scoring. Diabetic foot is definitely a burden. It's a disability, it's a reduction in the quality of life, increased mortality, and also an added cost to the healthcare system. This is a scary statistics that has been published in 2005 that every 32nd lower limb is amputated due to diabetes. This number has not changed so much as there haven't been enough studies regarding international numbers. Only recent studies have been in North America, which showed that now an amputation is every 30 minutes, not every 30 seconds, and that we are seeing a shift from major amputations to minor amputations. Almost 85% of amputation are always preceded with a foot ulcer. Lifetime risk of developing an ulcer is between 19 to 34%. And with the current statistics showing that almost 500 million people are living with diabetes worldwide, so 19 to 34% is a large number. 40% of those patients will have a recurrence within a year. After healing, almost 60% will have recurrence within 30 and 65 within 5 years. Almost 20% of foot ulceration lead to admission. Between 10 to 15% of diabetic foot ulcers do not heal. So that means with all the current interventions, all the current screening methods, we still suffer from chronic wounds that have poor healing capabilities. Prevalence of diabetic foot ulcer is worldwide 6.3%, and we're seeing the majority of prevalence mainly in North America and Asia, and the least prevalence was in Europe. Diabetes is more affecting in the male than the female, and more prevalent in type 2 diabetes. Here is showing a study where the majority of studies were done in Asia, very few studies in North America and Africa. Only one study was done in Bahrain to show the prevalence, and this was in 2007, showing the prevalence of 5.9%, which is very close to the average global prevalence rate. Prevention of diabetic foot ulcer is on 5 major steps. First of all is to identify the foot at risk, the routine inspection and examination, proper health education for patient, family, and healthcare workers, proper footwear, and recognizing and treating risk factors for ulceration. During my practice, I've noticed that the major problem was the health education of patient and family, as most of them don't really accept the fact that an ulcer in the foot is different than an ulcer anywhere in the body. First of all, how to identify a foot at risk. It's recommended that every diabetic patient should have an annual examination and annual screening of his foot to identify the foot at risk. This scoring system or categorization risk stratification system was introduced by the International Working Group on Diabetic Foot Care, with 0 being very low risk and 3 being very high with neuropathy and peripheral arterial disease. And according to these, they have introduced the different scoring system for the frequency of the annual screening. Some were introduced annually, some was every 3 months, some was every 6 months. According to severity of the risk stratification system, the Society of Vascular Surgery, American Diabetes Association, and International Working Group on Diabetic Foot Care, they all recommend the annual screening. Number 2 is the routine inspection and examination. Screening on a person, just one sec. Yes. Screen a person with diabetes at risk of foot ulceration, and especially with those with a previous ulceration, needs to have more frequent routine examination. Educating the patient. Through the years, it's been always the same recommendation for home screening. It's checking the foot daily, proper wash, proper care for the nails, proper footwear, proper glycemic control. All of them have been introduced and advised to the patient over the years. It hasn't changed for the last 10 to 15 years. Proper inspection and care for the foot at home. For education about foot self-care, provide structured education to a person with diabetes who is at risk of foot ulceration about appropriate self-care, as we mentioned before. Consider instructing a person with diabetes who is at moderate or high risk of foot ulceration to self-monitor the foot skin temperature once per day to identify any early signs of inflammation and help prevent a first or recurrent plantar foot ulcer. This is just few ideas how to instruct the patient to take care of himself at home. We talked about preventing. This one is in case an inflammatory process or in case an ulcer presents, we advise them and teach them when to seek medical attention. The appropriate footwear. Most patients that I've seen with diabetic foot, they all fail to use the appropriate footwear, whether it's an orthotic shoe, proper cast walker, offloading, all depending on their current state. There have been introduction of many foot care and footwear. Most of them, they have to rely on the fact that there are no pressure and no constricting. And we always advise the patient to use even one size bigger than their actual size. Cast walkers and total contact cast for those who need it. Proper insole, especially with patients with an active ulcer to avoid pressure and delayed healing. Proper footwear, especially for those with Charcot changes. And lastly, treating for the risk factor for ulceration. Risk factor include the callus formation on the foot, the ingrown toenail, fungal infection. All of these can predispose to an ulcer in the foot. And encourage the patient for exercises and weight-bearing activity, as exercises help with the neuropathy system, neuropathy symptoms, and they help with the vascularity. In the end, the take-home message, we need for a proper screening program at least once per year. Diabetic foot is a multidisciplinary team where we need to involve the diabetologist, the orthopedic, the vascular, and the physiotherapist. In the last few years, we have seen a decrease in the number of major amputation, a shift to minor amputation due to introduction of new modalities for treatment. But we're still lacking a lot of data about the screening and the prevention of diabetes. We are considering for more studies and more data regarding the intervention. As the present, all studies are focusing more on treatment and cost-effective modalities. And last but not least, the education should be targeted to all diabetic patients, their relatives, and also to healthcare workers. This is just a quote that I like that from Plato. The cure of many diseases is unknown to physicians because they are ignorant of the whole. For the part can never be well unless the whole is well, which can be applied to diabetic foot because you can never improve a diabetic foot without controlling the blood sugar and the diabetes. Thank you. Any questions?
Thank you very much, Dr. Ahmed, for this wonderful, short, but very sweet presentation. Must be learned from. Before I open the question for a couple of minutes for questions, just a question from my side.
Yes.
How about using hyperbaric oxygen therapy? Are you using it in your clinical practice?
Hyperbaric oxygen therapy has been in great debate for many years, and up till now, there hasn't been any study confirming the efficacy of hyperbaric in the use of or treatment of diabetic foot wounds. So it's up till now, it's not considered as a primary management method, but can be used as a secondary management method.
Okay. All right. Thank you. Any other question from the floor before I move on to the third speaker?
Yes, Dr. Sayed, there is one question in the Q&A from Dr. Muhammad Az Al-Arab.
Yes, I've seen that. Okay.
Yeah.
So it says, thanks, Dr. Ahmed. I have a question. Why callosity is more common in diabetic foot than in non-diabetic patient? And the second question is, any indication of doing angiogram in case of diabetic ulcer?
Okay. Callosity or callus formation is more common as due to the neuropathic changes in the sensory and the autonomic system, leading to increased dryness and increased deformity of the foot, leading to more friction and more stress on the plantar aspect of the foot, which lead to more callus formation. And as regarding to angiogram is, we use it, but it's not, it's after evaluation of the foot. And if we see signs of ischemic changes, of course, angiogram is very important to treat the ischemic changes.
Okay, moving on. I think there is a hand raised. I'm not sure if it's Dr. Ghazi or...
There's one more question, if it's possible, or no?
No, I think in the rest of time, we'll just take one. Okay,
I just want to emphasize one point, and that's most of these patients, they are on metformin, and metformin is associated with vitamin B deficiency. Okay, and so most of the patients with diabetic foot, I think they need vitamin B1 and B6. You know, it's very important. If you measurement and the treatment. This is one thing, you know, there is other things, you know, but I would leave it.
Thank you. Thank you, Dr. Ghazi, for your wonderful comments. And thank you, Dr. Ahmed, for the wonderful presentation.
Thank you
With
very
that,
much.
let me introduce the third speaker for this morning. And it's Dr. Bassem Mustafa. Dr. Mustafa is a senior consultant physician and rheumatologist at Bahrain Defense Force Royal Medical Services. And he's a senior clinical lecturer, Royal College of Surgeons of Ireland, Kingdom of Bahrain. And Dr. Mustafa is going to talk about updates in rheumatoid arthritis, how it can be treated early. So welcome, Dr. Bassem Mustafa. A very good morning. And you're ready to go whenever you are. Please go ahead, Dr. Bassem.
You can hear me now?
Yes, I can hear you. And I think
We
somebody's
just
helping you to share the screen. So yes. Yes, your screen is visible. Please go ahead, Dr. Bassem.
About to start there. He's making it ready. It's okay, can start?
Yeah. You can, please.
Yeah, Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Sayed, for this nice introduction. I would like to welcome all those attendees on this Friday morning and to thank the organizers of this meeting, the annual meeting of IMDO, to give me the chance to present my topic today. The aim of my presentation is basically to increase the awareness of this important disease, rheumatoid arthritis, and for the physicians of different specialties to be able to suspect at least if there is an inflammatory arthropathy and to be able to refer them to the specialty for further assessment and management if needed. As you know, rheumatoid arthritis is a symmetrical polyarthritis, we can say, with extra-articular manifestations. This means it affects some other organs apart from the joints. If we don't treat it, it can lead to serious disability and suffering for the patients. So it's very important to recognize the disease early. Why? Because most of the joint damage happens in the first 2 years. If the patient missed this chance and being untreated properly or with unnecessary medications or just analgesics, they will gradually lose the joint function and might go into dependency and lose their quality of life will be markedly affected. So not only early diagnosis, early treatment. As soon as you diagnose the patient with this disease, you should start treating this patient and treatment to target. This is our principle of treatment, so we can get the patient in a good state of health. As you can see here, some images from a normal hand, progressive changes, and the end lead to joint deformity, and even worse than this, what we can see here. And this is really preventable if we treat patients early. We do see some of them, those who are not treated for a long time and came to us late. And we try to maintain the function of other joints in order the patient can improve his quality of life. So we do see patients coming to the clinic, walking with a cane or in a wheelchair, or some time I have seen patients coming with a stretcher. And it's rewarding when you treat them, and within a few months you see them coming to your clinic walking. This is really make you happy and make the patients happy at the same time, which is very important. And the patient can lead a normal life. Rheumatoid arthritis, the prevalence is about 1%. It's increasing with age. And the most common age is the mid-decade, in the 40s to 60s. Women to men ratio almost 3 to 1. The concept of the treatment, as I mentioned, the treat to target. We have a target in many diseases in medicine, as you know, with the neurospecialties, you treat diabetes, you treat hypertension, hyperlipidemia, and we have targets for this. For example, for diabetes, you say we aim at an HbA1c less than 1%, for example, and with this we can prevent and decrease the complications, microvascular or macrovascular complications, and improve the patient's health condition. Again, for hypertension, we have also a target, for example, below 140/90, but in diabetic patients, we aim a lower value, 130/80 or a bit less. For hyperlipidemia or high cholesterol, we aim a target of 70 milligram per deciliter or a bit lower. With this, we can prevent premature death, complications, cardiovascular disease, and so on. So we have this principle also implemented in rheumatoid arthritis by measuring disease activity. I will point it later on. So treatment to target in rheumatoid arthritis. What is the aim of our treatment? We want to get the patient in a state of clinical remission. What do we mean clinical remission? The patient becomes asymptomatic, no joint pain, no joint swelling, no early morning stiffness, especially when they wake up in the morning. They won't have fatigue. Fatigue is an important symptom also of disease activity. And his inflammatory markers will be normalized, will be normal. Even his anemia might improve with treatment. So patient will be really better. Regards functional remission means the patient's function, as I mentioned, some patient coming in like in functional class 3, which means they are not able to perform well at work and not able to perform also some activities when they go home, like leisure sport, some activities. And we have seen them improving gradually to function class 2, doing well at work, some limitation with leisure, and even to class 1, fully functioning at work and outside the work. We have seen such patients. Again, radiographic remission is another important target. Joint erosion is important in rheumatoid arthritis and inflammatory arthritis in general. And at least we can stop the erosions from progressing or the joint damage from progressing and reverse it if possible to a certain degree. So the remission is achievable goal is said here, but actually full remission is very difficult to achieve. And now recently low disease activity becomes an accepted target. So the patient can lead a relatively normal life with some pain here and there, some joint, 1 or 2 joints swelling in between and improving. So we'll try our best to maintain the patient on medications, explain to them, and be with them regularly, with regular visits in the clinic, with regular assessment, and in order to prevent long-term complications. So if we treat early, as I mentioned, we can prevent progressive joint damage, whether we use disease-modifying anti-rheumatic drugs, which we call it DMARDs, or biological drugs. For this reason, there were some recommendations and principles set by experts from different countries. I just go through them based on their systematic literature review and their opinion. There are some like overarching principles, 4 of them, and 10 recommendations for the diagnosis, the follow-up, and the treatment. What are the principles? Very important. I think this applies in medicine in general, not only rheumatology. The patient has to be explained, and the decision about the treatment, medications, what suits him, what not suits him, what problem he has, what comorbid condition he's having, can he take this drug or can't? This is a decision between physician and patient. If you explain to them, they will be very happy and they know what they are taking and they will be compliant at the end with the treatment. And we tell them our goal is to get him in a good health for long term to prevent joint damage, structural joint damage, as you have seen the images. Again, inflammation has to be controlled as much as possible. No more inflammation. This means the patient becomes asymptomatic. because inflammation is the main culprit for this. Treatment to target strategy by measuring disease activity, which I'll show one slide later on. Here we can see the importance of inflammation. If we stop inflammation, which is the basis of the disease process, inflammation, there are pro-inflammatory cytokines produced by the body which target the joints and can lead to joint damage, joint swelling, pain, stiffness, and this lead to joint damage and limited function. By stopping the inflammation, which is the key in the management, patient will be really doing better. So what are the targets of the treatment? Get the patient, as I mentioned, in a state of clinical remission, no signs or symptoms of disease activity, low disease activity, as I said, is accepted target. We have to, until we reach the desired target, we have to adjust the treatment regularly. Initially, we see the patients more regularly, and later on, every 3 to 4 months, usually. We measure the disease activity. There are some scores. I will show them in brief at the end. Initially, we check them monthly, and then later on, maybe every 3 to 6 months. There are validated composite measures are used. I mentioned some of them later on. So preventing structural damage is our aim at the end. We have to maintain our treatment throughout the course of the disease. And if possible, we can also start reducing even our treatment, our medications to reduce the side effects. If the patient remains free of symptoms for a year or more than 1 year, we can try gradually to withdraw the treatment slowly. We have managed to get some patients off medications over time or with minimal drug usage. Well, this is our aim. So we can reduce, by this, we can reduce the possible side effects of medications. As I mentioned, composite measures of the disease activity are used. We have to look into patients' comorbid conditions, like is he diabetic, does he have renal failure, does he have liver disease, which drugs can I use? And we have to monitor all this. It's very important. We know rheumatoid arthritis is inflammatory, and many other conditions in medicine are inflammatory. And those pro-inflammatory kinds also increase the risk of those rheumatoid arthritis, even to develop diabetes, because they share some of the pro-inflammatory cytokines. Even obesity is one factor that the response to the treatment is less than those who are non-obese. It has been shown by some studies. Smoking also bad for all patients in general, and even the response to treatment is less than people who are not smokers. So we will advise the patients, same what you advise your diabetic patients, to maintain ideal normal body weight, good healthy diet, avoid junk food, stop smoking, and so on. They are very important factors, lifestyle modification. The patient has to be informed about the treatment regularly and assessed for taking the medications, and if needed, adjusting or withdrawing gradually. Here regards the treatment itself, we go through different phases of treatment. Phase 1, we see that we make our diagnosis. As you see here, there's no pointer. Here is okay. If we make our clinical diagnosis, we look if there is contraindication or no to methotrexate. This is the first drug we are using, methotrexate, and if we achieve the target or improvement in 3 months, we continue. By 6 months, we should achieve a good result. Then we'll continue. But if we don't, we have to look for another drug and add another drug. Usually, we add the drugs like leflunomide, sulfasalazine, and again assess. And if the patient responds, we give combination of disease-modifying anti-rheumatic drugs. We combine initially short-term steroids. Steroids, they have a lot of side effects. We try to avoid them as much as possible. But the advantage of steroids, when the disease is really active, it's very difficult to control it without steroids initially. Those DMARDs will take time to work, up to 3-4 months, some of them, gradually onset of action. So we try to give initially, and we try to reduce, and try to maintain if patient need less than 5 milligrams per day of prednisolone. And usually we cover them with give them vitamin D supplement in order, we are worried about osteoporosis, as most of our patients above 40, above 50, many of them post-menopause, and they're at high risk of osteoporosis. If we predict that the patient might need higher doses of steroids, like, for example, lupus patients, sometimes initially with major organ involvement, they might need more than 3 months, a dose more than 15 or 20 milligram. Those we cover them with drugs that treat osteoporosis, like we give them annual injection of zoledronic acid, for example, to protect the bones. This is very important, and we advise them about some lifestyle modification, food rich in calcium, like dairy products and others. If patient not responding to this combination, and we go to phase 2, depends on unfavorable factors are present or absent. If they're absent, as I said earlier, we can use combination of DMARDs. Initially, change of them, but in general practice, we add combination more than changing. Methotrexate is usually part of the treatment unless not tolerated by the patient. But if the factors like very high titers of rheumatoid factor or anti-CCP antibodies and high disease activity by measuring the score of the disease, then we will go for biologics. The choice here between two things, TNF alpha blockers or JAK inhibitors, and then we monitor. If they respond, we'll continue. If they don't respond well within maximum 6 months, we go to phase 3. Phase 3, we go to another group of biological DMARDs, apart from the TNF blocker. We can go use T-cell inhibitor like abatacept, or IL-6 inhibitors like tocilizumab. And if the patient responds well, we maintain this treatment as long as he's improving, maybe 1 year, 2 years, 3 years, can be longer. Finally, if they don't respond, here, rituximab, usually we use it as the last resort, which is used in resistant cases, and we leave it until the end. Application in clinical practice, we try as much as possible to use those medications if needed. The problem sometimes there that the biological drugs are expensive, sometimes not available. But in the last few years, we have biosimilars, what we call biosimilar. They work the same way that the original biological drugs working, with more cost effective. We can use biosimilars and save money, and more patients can be treated. How to measure disease activity? I will show you in the coming slide. Here, one question: can we rely on SR and C-reactive protein alone to give us clue about disease activity? I give you 10 minutes to think about this. So the 10 minutes are over. So the answer is no, because in clinical practice in general, we see SR high, for example, SR of 8 in a patient with no active disease, no joint pain, no swelling, as well as CRP. And we see patients with active disease, SR is normal. So clinical assessment is always important. So they are not always reliable. We use them. In some patients, they go with the disease activity and they drop when they improve. But in some patients, they are high despite disease is controlled, and we might look for other reason for high SR, high C-reactive protein. Maybe the patient has another hidden medical problem. We should keep this also always in mind, like malignancy, some other conditions. Our patients are at high risk of other complications, and we have to keep eye on this. So there are the measures I'm talking about. Simplified disease activity score, something called clinical disease activity score. We depend on 28 joint count, as you can see on those images. 10 joints in the hands, plus 8 large joints, shoulders, elbows, wrists, and knees. So, and this just those are done by calculator, by the way. So you enter these values, and that will give you an answer. Here we can see like the total joint count, 28, how many joints are tender, and here how many joints are swelling, and the square root, and so on. And we target a certain value below which the disease is clinically inactive. But sometimes they have their pitfalls, and you can have low score despite the patient's active disease, or high score and the disease is inactive because SR is high or C-reactive protein is high. And is inactive, it will give you a high value, tell you the disease is active. So you have to be careful about this. Clinical assessment is always important. So in summary, I mentioned most of the points. It's a progressive disease, can lead to joint destruction and improve quality, affect quality of life, the use of DMARDs, biologics. We treat at remission, not achieve at least low disease activity. We use traditional DMARDs, if no improvement, biologics. We monitor also radiological changes by doing initial X-rays, and later on we'll do follow-up X-rays, looking for erosions, some other changes like periarticular osteopenia, and so on. The treatment is supported by international guidelines, which are keep updated every few years. And patients usually we follow them every 3 to 4 months in general. So in conclusion, early treatment diagnosis, very important. Early treatment, very important. Implementing the strategy treat to target is very important. With this, I would like to thank you and wish you stay healthy for life. Thank you very much.
Thank you very much, Dr. Basim, for this wonderful presentation and very informative. Let's open the floor now for any question, 1 or 2 questions we can take. I don't see anything in the chat box.
Can I have a question, please? Dr. Basim,
Yes.
very nice topic, and really the signs you show for early pickup of the patients with arthritis. So
Yes.
we face many times patients with the typical criteria, and we check for their latex and TCCB, and both are negative. So what do you suggest in these conditions?
Yeah, for us, it doesn't need to be positive. You have seronegative rheumatoid arthritis. Yeah, up to 70% usually in general, I can say general, around 70% will be seropositive. About 30% will be negative. So you have to see rheumatoid factor negative and TCCB negative, but patients having rheumatoid arthritis. So that's why it's very important when you have suspicion, even if you screen and even negative, send them to us for further assessment. And we can diagnose them even with negative serology, and we treat them. It's very important.
Yeah, you're right, because as you said, it's not necessary. So this is, it be message for all attendees that any patients with the negative, or seronegative or negative test should be referred to the specialist.
Exactly.
For further management.
100%. Yeah, this was the aim of my presentation, to increase the awareness. And if you even have some suspicion, send them. At least we can work them up. You know, arthritis can be also another disease, not necessary to be lupus, can be part of a mixed connective tissue disease, can be a part of lupus, for example. That's why we tend to do also, I won't go deep now, but we do anti-nuclear antibodies, and if it's positive, we'll proceed for the structured nuclear antigens, the double-stranded DNA, and so on, because inflammatory arthritis is not limited to rheumatoid arthritis. And we have seen patients, unfortunately, go from one place to another, from a health center to some clinics here and there, and getting analgesics, non-steroidals, physiotherapy for a patient with rheumatoid arthritis. Can you imagine, with joint pain? When there's active joint, you have to have rest, and they give them the physiotherapy. We have seen patients suffering a lot. After suffering a few months, we have seen patients. Maybe the time is not allowed, but I have many examples can mention. So we have to be aware of this problem, and the patient, whoever comes to, because many patients think it's an orthopedic problem, joint pain, because they think ortho doctor are the joints. They are surgeons. They deal with joint replacement mostly, right? And physicians need to manage. I have seen some managing them, unfortunately, unnecessary, They have to stop medications and some given by some private practice doctors. We need people to be aware of this. Better to leave it to the specialist in order to monitor side effects. Can we use this drug? Can we not? Look for comorbid conditions. Also very important when you treat a patient. For example, rheumatoid arthritis have high risk of cardiovascular disease. We know this, right? And many of them have a increased mortality because of this. Because again, inflammation leads to increased plaque formation in the arteries. They can get stroke, MI, and so on. So we have to keep eye on all those issues. Not only I'm managing rheumatoid arthritis, I manage this and refer them also if needed to a cardiologist or other specialists in that field. We don't keep them with us. Even I might need to refer to you as an endocrinologist for better control of their diabetes. I measure their HbA1c as a physician. I am not a diabetologist, but I'm a physician. I leave it to you to monitor in order to control them well, to prevent renal damage. Many end with renal dialysis, untreated well and treated by non-professionals or somebody who is not aware of those complications. So your point is really very valid, and I thank you for this question.
Thank you, Dr. Basil, for a nice lecture. Now we will shift to the next speaker. It's my pleasure to introduce Dr. Sayed Raza. He's a consultant cardiologist and physician. Thank you, Dr. Basil. Head of Department of Medicine in Awali Hospital, Fellow of Royal College of Physicians of Edinburgh, Fellow of American College of Cardiology, European Society of Cardiology, European Society of Cardiovascular Imaging, and European Board Certified in Heart Failure, American Board in Medical Quality. We have Diploma in Medical Education, University of Cardiff. Well, he's Regional Coordinator, Medical Education, Royal College of Physicians of Edinburgh, Examiner, PACES Exam, Royal College of Physicians, UK. Author of the books, Personal Experience with the COVID, published November 2022. So Dr. Sayed, the floor for you. He will present very interesting topic today.
Thank you very much, Dr. Asad, for the very kind introduction. I hope you can see my screen and you can hear me as well.
Everything is okay and clear.
Okay. Right. Okay, so in the next 25 minutes or so, I'm going to talk about obesity and how it poses risk as far as the cardiovascular system is concerned. I'm going to talk about as to how the paradigm shift has taken place in the last few years in managing obesity. And then I'm going to provide some evidence-based anti-obesity therapy that influences cardiovascular outcome. We all know that obesity is now a global pandemic, and 13% of the world's population is suffering from obesity. And it is predicted in the next 1 decade, half of the world's population will either be overweight or obese. Now, the assessment of obesity has changed over a number of years. And we all started with a weighing machine. We are still with the weighing machine. This is the commonest tool that we will see in every physician's room. But we don't really know that what we are assessing, what we are measuring. Are we measuring patients' fat weight? We are measuring patients' muscle weight, the bone weight, or is it just the water or the mineral? We did move forward a little bit, and we started to assess the obesity by using body mass index, where height was taken into consideration in addition to the body weight. And some of the researchers have used body mass index in looking at some of the outcomes related to obesity. Then we moved on to measure the abdominal girth or waist circumference. And this has also been used in some of the studies to measure the waist circumference and also the waist-hip ratio. But if the person is morbidly obese, we really do not know what we are measuring. We do not know where the waist is, first of all. Then we moved on to measure the subcutaneous fat with the help of a caliper, but this does not become very popular. And then there are some modern machines which can estimate the body composition and looking at the fat distribution in the body. But this also has got high rate of inaccuracy. Now, the best way forward we can predict cardiovascular risk is using the visceral fat. Now, visceral fat, for those who do not know, is a fat that is deposited inside your abdomen, mainly around your internal organs, such as around the liver, pancreas, spleen, and kidneys. Now, this gives a very good predictor value for measuring the cardiovascular outcome, and that predicts how your risk is, how greater your risk is for developing heart attack or stroke in the future. Now, bone marrow density machine is good enough to assess this, but better than this, we have other machines like MRI and PET scan, which is again not readily available everywhere, can give you a good assessment as to what the distribution of this visceral fat is. Now, we know by now that obesity contributes to cardiovascular risk. Factors such as hypertension, diabetes mellitus, dyslipidemia, and obstructive sleep apnea. And now we consider obesity as an independent risk factor for cardiovascular mortality. So this is important to keep in mind, that obesity indeed is an independent risk factor for cardiovascular mortality. And cardiovascular mortality is directly related to increasing BMI. Now, this is a data from the regional studies done in UAE in 2019. And that has very clearly shown that obesity is the biggest risk factor for death. So what is abnormal? What are the abnormal pathophysiological changes that take place in obese person? These patients are diabetic, they are obese, and they are insulin resistant. They do have the other risk factor, develop risk factors if they're obese, like dyslipidemia, high blood pressure. Then there are some neurohormonal changes. Then there are endothelial dysfunction in the vasculature throughout the body. And we all know that obesity is a low inflammatory process, and it also initiates a pre-thrombotic state by increasing the inflammatory cytokines. And the end product is an effect on the cardiovascular system. It does lead to increase in the prevalence of coronary artery disease, increased prevalence of peripheral vascular disease, cerebrovascular disease, and also arrhythmia, mainly atrial fibrillation, and heart failure, mainly heart failure with preserved ejection fraction. And we should not forget that morbidly obese patients who are very, very obese with a BMI of perhaps more than 40, they are also at risk of sudden cardiac death. To discuss some of the numbers in obese patients who have got body mass index of more than 30, they are at 3% increased risk of stroke. There's 3.5% increased risk of congestive heart failure. There's 8% increased risk of ischemic heart disease, 21% increased risk of myocardial infarction, and as high as 51% increased risk of hypertension. So what is the solution? And the solution is simple in terms of saying it, that lose weight. But we know from our clinical practice is not that simple and easy. But we have got to encourage our patients. That is the only means we have to prevent cardiovascular outcome in these patients. And the studies have shown that weight loss of as low as 0 to 5% can have a good predictive outcome on hypertension and hyperglycemia. And as you lose weight up to 5 to 10%, 10 to 15%, and if the weight is lost more than 15%, we see the cardiovascular benefit. Weight loss of more than 15% has shown to cause type 2 diabetes mellitus remission, a positive outcome on the cardiovascular mortality, and also prevents heart failure with preserved ejection fraction. So the obesity management is continued. We do advocate lifestyle changes to start with, and then with a period of time, there are more of pharmacotherapy, lifestyle changes continues, and then we resort to using the surgical options, which we leave it for the last. We do not encourage. But the trend, as you will see, I meet a lot of patients, the younger patients, they want to go from zero. They don't even think about lifestyle modification. They talk about gastric sleeve or gastric, even gastric bypass surgery. So this is something as a clinician we must keep in mind, that yes, these therapies are available, but this is not for everybody. We must take into account that no, there's no easy path in losing weight and managing obesity. And that is something we must discuss with the patients when they come for a simple solution of weight loss. So lifestyle modification and subsequent weight loss did bring about some change as far as the metabolic syndrome and the systemic inflammation and endothelial dysfunction is concerned. But a scientific statement from the American Heart Association in 2021 published in Circulation very clearly stated that there are some clinical trials and that medical weight loss have not demonstrated any positive cardiovascular outcome. So lifestyle modification, we all know, is the cornerstone, is the fundamental for managing obesity. And we know very well that it includes diet, exercise program, and behavioral adjustments that should be involved in managing obesity. And lifestyle modification has been shown to decrease weight of 3 to 5% of body weight loss. Now, this is a look ahead study. And this study, let me tell you, ladies and gentlemen, this was halted early because it did show that intensive lifestyle intervention, which means very strict dieting, good exercise program, and behavioral changes, actually failed to show any positive cardiovascular outcome benefits. As you can see on the panel right-hand side, the intervention was very similar to control in terms of reducing the cardiovascular death, myocardial infarction, or stroke. And this trial was halted after conducting a trial for 11 years. But it did show some loss of weight, 8.6% on average, and significant reduction in HbA1c, as well as reduction of several cardiovascular disease risk factors. So there has been a paradigm shift of using exercise or diet as a lifestyle measures to depending more on the pills and the injections, and of course, the bariatric surgery. There are some trials that you can see on the screen and that have used the medication for these trials for obesity management. And these have been studied in some of the cardiovascular outcome trials. Now, let me remind you that these trials, some of them, they did not complete because of the adverse effects that were seen with the active agent or the trial agent. And some of the agents were actually stopped once they were approved, and then they were stopped or withdrawn from the market because of the adverse effects. So now none of these medications are currently in use in terms of obesity management for the given reason I've just mentioned. So until recently, it was a clear statement from the all guidelines that there was no anti-obesity medication just to treat obesity in patients without diabetes that had shown any superiority as far as the cardiovascular outcome is concerned. So in 2012, when the adverse effects were seen with anti-obesity treatment, the Food and Drug Administration laid out certain guidelines to do cardiovascular outcome trials in obesity based on similar guidance that was given for cardiovascular outcome trials for newer anti-diabetic drugs in 2008. And so in 2015, the European Medicine Agency provided very similar recommendation as above. And so there was some strict criteria and guidance to the trialist as how a study was designed. So they looked at and guided that study population should closely match the target population on which these drugs will be used. The study duration has got to be long enough to pick up the cardiovascular events, and the safety outcomes should be done using 3-point MACE, which includes cardiovascular death, non-fatal MI, and non-fatal stroke. And additional parameters should be looked at as the occurrence of heart failure, arrhythmia such as atrial fibrillation, and dyslipidemia. So the margins that were looked at by the regulatory decisions by FDA guided very clearly that if the hazard ratio was more than 1.8, then certainly the drug will not be approved. If the hazard ratio from the trial of cardiovascular outcome trial showed that the hazard ratio was between 1.3 and 1.8, then these trials would need post-marketing trial before they could use the drugs. And if the hazard ratio was less than 1.3, then they were good enough to be used in the patients, and a post-marketing cardiovascular trial was not necessary. So here is a timeline of FDA-approved GLP-1 agonists over a period of time starting all the way from 2014 and completed a decade. And we have a number of them. So these GLP-1 agonists were initially approved for management of diabetes. And as we saw that they also help patients to lose weight, then they became a drug for obesity management. And some people, they call it a wonder drug because obesity is indeed a problem, which patients see more of a problem than diabetes in itself. Now, these drugs have been approved not only for the adult patients, but also for weight loss in adolescents and children. So this is one of the meta-analysis that concluded from 4 trials where they studied more than 3,000 patients that once a week semaglutide was superior to placebo in terms of percentage of absolute body change, BMI, and waist circumference. There was improvement in cardiometabolic risk factors and better health related to quality of life, but no mention about the cardiovascular outcome. Then came the SUSTAIN 6 trial. There is also Pioneer 6. Pioneer 6 was done with oral semaglutide and SUSTAIN 6 with subcutaneous semaglutide once weekly. And this was compared with placebo. And here, what they were looking at the primary outcome, cardiovascular death, non-fatal MI, or non-fatal stroke. And after a period of follow-up, a very long follow-up of 104 weeks, it showed a benefit in favor of semaglutide, as you can see here on the screen, compared to placebo. Although the benefit for superiority, as evident by the p-score, was just marginally superior, but it was highly statistically significant for non-inferiority compared to placebo. So the bottom line is this: the semaglutide did improve the cardiovascular outcome in this group of patients compared to placebo. Now, talking about another trial, semaglutide, looking at, once again, the cardiovascular in obesity, but this time, mind you, these patients were not diabetic. In SUSTAIN trial, all the patients were diabetic, but they had established cardiovascular disease. About 80% or 87% of them had established cardiovascular disease. But now this trial is entirely in patients who do not have diabetes. Now, again, what we're looking at, can these diabetic medications be only used to help the patient to manage diabetes and also to help them live longer and prevent the cardiovascular events? So this is a SELECT trial, and the SELECT trial essentially was to answer the question, can semaglutide reduce cardiovascular risk associated with overweight and obesity without diabetes? That is important, without diabetes. And this is a double-blind randomized placebo-controlled trial, and where they studied more than 17,000 patients, and one arm were given semaglutide 2.4 milligrams subcutaneously once weekly compared to placebo. And the duration of follow-up was almost 40 months. And the primary endpoint they were looking at is very similar, 3-point MACE, cardiovascular death, non-fatal MI, and non-fatal stroke. And at the end of the studies, the semaglutide group clearly benefited in terms of reducing the cardiovascular outcome, improving the cardiovascular outcome, I would say, reducing cardiovascular death, non-fatal MI, and non-fatal stroke. And the p-value, as you can see here, is highly statistically significant. So this is quite a landmark trial to remember for everybody, and that this is a SELECT trial that has shown a very clear benefit in favor of semaglutide in terms of reducing the cardiovascular events. And the percent of relative risk reduction is 20%, mainly driven by non-fatal MI. It did not show much benefit alone in cardiovascular death, non-fatal stroke. There was also some benefit in heart failure and all-cause death. So now the question is that what are the potential mechanisms as to how GLP-1 agonists, here I've written tirzepatide, which is another GLP-1 agonists, more modern, I would say, GLP-1 agonists. How do they impart cardiovascular benefit? Now, we all know that these medicines have clearly shown that they help to reduce body weight up to 10 to 21%. They lead to a good glycemic control. They have some effect on blood pressure. They improve your lipids, and they also have got anti-inflammatory property. So putting all together, they do have a very good cardiovascular protection mechanism. So SURPASS study was done. There were quite a few of them, SURPASS 1, 2, 3, 4, 5. And each of the studies essentially were studied against tirzepatide, against placebo, against semaglutide, against insulin degludec, and insulin glargine. And they were essentially looking at as to how tirzepatide was superior or how it fared in terms of reducing this HbA1c, systolic diastolic blood pressure, body weight, LDL, and triglycerides. And as you can see here on the slides, that tirzepatide showed a superiority against its comparators in all the trials, SURPASS 1 to 5. Now, the subgroup analysis from these trials were done now to mainly look at the cardiovascular benefit. And as you can see here, the patients who received or they were in the arm of receiving tirzepatide benefited in terms of cardiovascular outcome compared to comparator. There's another study, SURPASS cardiovascular outcome trial, that is especially looking at the effect of tirzepatide, comparing it against dulaglutide, which is another GLP-1 agonist, on major adverse cardiovascular events. Here they studied more than 13,000 patients, randomized double-blind. The study concluded in October 2023, but we are yet to get the results of these studies. And there's another study on the way, SURMOUNT MMO, which is once again looking at, it's a double-blind placebo-controlled trial, looking at the effect of tirzepatide on the reduction of cardiovascular mortality and morbidity in adults with obesity again. So no diabetes here, just in obesity. And the results, the study is estimated to be completed in 2027. Now, very quickly, I'll shift gears and talk about a little bit on heart failure and as to how this medication helps patients in preventing heart failure, particularly with preserved ejection fraction. Now, the STEP heart failure trial, this was very recently published just last year. And the question here was to answer, what is the impact of semaglutide on obese patients with heart failure with preserved ejection fraction compared to placebo? Not a very big study population, about just over 500 participants here. And they were randomized 1:1, one arm receiving semaglutide and the other arm receiving placebo. And what they were looking at mainly, not the cardiovascular benefits in terms of cardiovascular mortality, but mainly changes in the Kansas City cardiomyopathy questionnaire, which is a way to assess the symptom improvement, a way to assess the whole of the lifestyle changes in the heart failure patients, including the 6-minute walk, as well as the body weight. And the conclusion drawn from this study is that in heart failure patients with preserved ejection fraction, patients who received semaglutide did improve in terms of weight loss and heart failure symptoms. And semaglutide also helped them to improve the functional status and exercise capacity. So there's another study, SUMMIT trial, that is coming up using tirzepatide in heart failure patients with preserved ejection fraction. And the trial will conclude in July 2024. And let's hope to see a result with this molecule as well. Very quickly, last few slides. How about the surgical intervention, bariatric procedure? It has been studied to see the cardiovascular benefit, and a number of prospective and retrospective cohort studies have already shown that all-cause mortality is somewhat reduced. But the most important parameter that has been helped and has shown a very clinical and significant, statistically significant improvement is a reduction in stroke. So the reduction in stroke is one of the parameters that these patients, obese patients, are helped with if they undergo bariatric surgery. And this is a Swedish obese subjects SOS trial where bariatric surgery, obese patients who underwent bariatric surgery did have a positive cardiovascular benefits compared to patients who did not undergo bariatric surgery for managing their obesity. So in conclusion, ladies and gentlemen, we all know that obesity is an independent risk factor for cardiovascular disease. And now it is very clearly evident, as what I have shown, that there is a paradigm shift as to how we manage obesity in 2024. Newer anti-diabetic medications have now not only shown to provide good glycemic control, but a significant reduction in weight. Now you will all be aware of a saying that you can kill 2 birds with a stone. And here I say you kill 3, maybe 4 birds with a single stone. These drugs, they help you to not only have a good glycemic control, they help you lose weight, but also prevent heart attack and stroke. So this is something we need to discuss with our patients when we advocate these kind of therapy to patients who want to lose weight. But again, we should not forget that lifestyle medication is the first and the cornerstone management in obesity. Now, positive cardiovascular outcome that I have shown have been shown to with some of these medications, even in non-diabetic population. That is important. Patients who are non-diabetic, who are just obese, morbidly obese, who fail to lose weight with the lifestyle medication, then certainly they will benefit from these medications that are in the market. And several cardiovascular outcome trials and studies with anti-obesity medications are still underway. And this is, again, a very interesting area. We are seeing a lot of medication from diabetes. They are becoming either heart failure medications or anti-obesity medication with a very, very positive cardiovascular outcome. And we as cardiologists are very glad to see these medications in the pipeline. And with that, I thank you very much for your listening. And if there are questions, then I'm ready to take one. Thank you so much.
Thank you, Dr. Sayed, for your interesting topic and to be in time.
Dr. Sayed, an excellent presentation. I just want to emphasize what you said, lifestyle, no doubt that, I mean, this drug is still very expensive, okay, and for the patient. First question, do you think that these drugs, they have independent action on the heart, okay? And that you mentioned some of it, no doubt, And the other things, who could afford it? I mean, this country and other Arabian country, they may not afford this. So the government should interfere, and we should interfere about changing the lifestyle. So weight loss and improvement in the heart would be due to lifestyle, especially reducing the carbohydrate or limiting carbohydrate if possible. Can you comment on this?
Yeah, no, I think that's a very good point, Dr. Qazi, and I entirely agree that lifestyle is something that has to be advocated in every patient that we see through our door. Obese patient, no, there's a fashion, the youngsters who are obese, they do not want to move, do not want to exercise, do not want to diet, and they want to choose this shortcut, which certainly should be discouraged. But on the other hand, we must not forget that science has advanced, and the patients who have struggled to lose weight, by all means, they have tried and tried and tried, and they have got other comorbidities to an extent. They may suffer a heart attack at some point or heart failure, God forbidden. So these are some of the patients we have got to use these medications, which are available to us. Yes, I entirely agree that they're very costly, but again, that is something not in our hand. But if it can be made available, then certainly they should be used. The other question you asked, whether they have got a direct effect on the heart, we do not know yet because science is still out there. A lot of trials and researches are still going on. But yes, there is some interdependence, and the heart and the diabetes, they are interlinked in various pathophysiological ways. So I'm sure there are some benefits that we see, these cardiovascular benefits, which have shown as to how obesity reduction can have a positive impact on heart.
Thank you, Dr. Sayed. Professor Abdul Mohsen, you have another comment?
Sure.
Thank you, Dr. Said, for this excellent presentation. Now, do we have evidence that is this effect long-lasting or not? An example, somebody stopped this medication, what happened to the effect of the heart? And patient regain weight, what happened to the heart?
Yeah, I think that's again a very good question. So I can answer the first one, which is easy, which I didn't show in the one of my slides. But there is evidence that once these patients are started on the medication to manage obesity, and after a period of time, if they stop this medication, then the weight loss is going to come back. That means they are going to regain weight. And there are no trial that has that, to my mind, that has been done to what happens to the cardiovascular status. But I'm very sure that they will return to where they were. So the risk will come back as they were before they lost weight. And once they gain weight, then they will have the cardiovascular risk again because of the very understandable pathophysiological mechanisms we understand with the obesity.
Thank you very much.
Thank you.
By this, we will close this session and we will have a break. Then we will resume after the prayer time.
Good morning, good afternoon. I'm Dr. Rabaa Al-Hajri, and I will be chairing this session. We have lineup of expert speakers who will share their insights on the latest developments in diabetes research and management. The first part of this session will be discuss the latest update on diabetes gastroparesis by Dr. Hisham Khalfan. Dr. Hisham Khalfan, he is a consultant internal and diabetologist at Salmania Medical Complex Governmental Hospital, where he is head of the General Internal Medicine Units and run the GI Filter Clinic and the Department of Internal Medicine. Dr. Hisham graduated from American University of Beirut Faculty of Medicine and completed internal medicine residency at the Indiana University Schools of Medicine, certified by the American Board of Internal Medicine in 2005. So join us to welcoming Dr. Hisham Khalfan. Dr. Hisham, the floor is yours.
Good morning.
Good morning, Dr. Hisham.
All right, very nice to be at the 6th edition of IMDO and present this lecture, which I had given several years ago. I was hoping to present some groundbreaking updates on the matter. Unfortunately, we don't have a whole lot, but I'll try my best. Just wanted to give you a little background about my collaboration with the field of gastroenterology. I graduated from internal medicine residency in 2005. I was intent to enter, in a way, into gastroenterology, but I was lured into becoming a hospitalist by my first CEO. He was able to convince me that it would be a more rewarding and appropriate fit given what he had known about me. And I became a hospitalist in the city of Indianapolis. I did that for several years, and the rest was history. My recent interest in gastroenterology, specifically in what concerns diabetic gastroparesis, was first invoked when I was part of the bariatric surgery team at the Bahrain Defense Force Hospital in 2012. I did that for about 5 years, and we had a very tight-knit unit. We were involved with many surgeries and had 2 accreditations, European and international. And then most recently, 6 months ago, I was requested by my department head at Salmania to assist the gastroenterology unit, where Dr. Ahmed Al-Sayah was very welcoming and receptive of the idea of having an internist manage the simpler cases of gastroenterology, the ones that did not require endoscopy, surgery, or other invasive interventions. So, starting my lecture here, what is diabetic gastroparesis? It's a condition where we have impaired motility of the stomach, which is formally diagnosed without the presence of obstruction, leading to multiple symptoms. Instead of moving at a decent pace, we have reduced motility, and sometimes it can be confusing because the patients don't necessarily look sick, and we don't always have red flags. As I said, it's a form of gastric paralysis with chronic symptoms resulting from abnormal gastric motility associated with delayed gastric emptying in the absence of mechanical outlet obstruction. The symptoms are variable, just like many GI symptoms are, including nausea, vomiting, abdominal bloating, early satiety, and abdominal pain or discomfort. They may mimic certain structural disorders such as PUD, intestinal obstruction, pancreobiliary disorders, and there can also be an overlap between them and another domain which was addressed yesterday by Dr. Ahmed Al-Sayer, which is functional dyspepsia. The relationship to objective gastric motor function is not always one-to-one. So patients could have slightly reduced motor function with significant symptomatology or the other way around. However, there is always objective evidence of an impairment in motility. Diabetic gastroparesis is neck and neck with idiopathic gastroparesis as the two most common causes of gastroparesis, 29% versus 28%. So more than almost 60% of the causes are between these two causes. And then we have Parkinson's, we have post-surgical, post-viral, pseudo-obstruction, scleroderma, and miscellaneous causes. So as you can see, this is a very common cause of gastroparesis. The epidemiology is overwhelmingly female, about 80% or more. The delayed gastric emptying is found in 20 to 40% of patients with functional dyspepsia and a little more in the diabetics. And the incidence over 10 years is about 5.2% in type 1 and only 1% in type 2. However, because type 2 diabetics are overwhelmingly more than type 1 diabetics, we generally see more patients overall who are type 2 than type 1. The players or the culprits in this disease are multiple, which makes it so interesting and also very frustrating to manage and to cure. We have the parasympathetic and sympathetic or the autonomic nervous system, along with the enteric, and the involvement of multiple neurotransmitters, hormones, along with the effect of food composition on the disease, which affects the treatment as well. So when we talk about the interplay of etiological factors, we just want to keep in mind that we have three main affected entities, one being nervous, autonomic, and enteric. The second being the mediators, which are the interstitial cells of Cajal, which basically take the signals and relay them to the smooth muscles. In terms of subsystems involved, we have afferent receptors, neurohormonal substances, and circulating hormones. The effect of these has to control the myoelectrical activity and so the frequency of spike potentials leading to the contractions. And the correct physiology involves a tonic contraction of the fundus, phasic contraction of the antrum, and then inhibitory forces of pyloric and duodenal contraction. Here it shows you the interplay in a diagram. CNS decides things and sends signals to the autonomic and the enteric nervous system. The enteric nervous system interplays with the interstitial cells of Cajal, affecting wave propagation, stimulation, and mediation of motility. The autonomic nervous system vis-a-vis the sympathetic and parasympathetic nervous systems have a say in what concerns motility and sphincter tone. So a lot of things in play. This here is a pictorial depiction of how things happen. We have the accommodation in the fundus, followed by emptying, and the pacemaker controls the waves in that regards. We have filling, mixing in the corpus, antrum, And then we have emptying through the pylorus, where we deal with contraction and relaxation. And finally, there is also an element of variability introduced by the duodenum. Now, what happens with diabetic gastroparesis? As we all know, we have autonomic neuropathy that doesn't only affect blood pressure, it also affects the gut, as I showed, vis-a-vis the sympathetic and parasympathetic nervous systems. We have loss of nitric oxide synthase, as well as increased oxidative stress with loss of regulation of protective enzymes such as hemoxygenase 1. The loss of the interstitial cells, which I mentioned were the mediators, leads to gastric arrhythmia and delayed gastric emptying, smooth muscle atrophy and loss of IGF-1 from the smooth muscle, and loss of macrophages expressing hemoxygenase 1. So the various affected areas, the earlier diaphragm I showed you is how things move when they are normal. However, with diabetic gastroparesis, we have the presence of advanced glycation products inhibiting nitric oxide synthase, impairing neurotransmission and delaying gastric emptying. We have autonomic neuropathy implicating the functioning of the fundus and other parts of the stomach, increased oxidative stress, pylorospasm, smooth muscle atrophy, and impaired antro-duodenal coordination. How do we diagnose and evaluate this condition? We have to demonstrate delayed gastric emptying in a symptomatic individual after exclusion of other etiologies of symptoms. So we have suspicion in diabetic patients. We see it quite a bit, as I mentioned earlier, in functional dyspepsia, and also in patients with a gastroesophageal reflux disease and after vagotomy profiles. So, of course, we require initially complete blood work. Just to mention, of course, the physical exam is not very revealing. We could see signs of halitosis, dehydration. In some cases, we could have increased weight, but it's mainly with the investigative studies that it's diagnosed. So CBC, check for electrolytes, creatinine, total protein, albumin, calcium, pregnancy tests in females, abdominal obstruction series if the vomiting or pain is acute or severe. Most, if not all, patients require upper endoscopy to check for mechanical obstruction, mucosal lesions such as peptic ulcer disease. We check ultrasonography to rule out gallbladder and biliary pathology. And then, of course, we have the gastric emptying tests and checking for secondary causes such as thyroid, autoimmune, followed by the different treatment modalities, which we will get to here in a bit. So as I stated earlier, in history, we confirm the relevant etiological or the epidemiological factors. If the patient is female, we'll be more suspicious. Poor glycemic control, especially over more than 5 or in more than 10 years, also gives us a much higher incidence of diabetic gastroparesis. Patients who have been taking GLP-1 agonists, and this was discussed in lectures yesterday, have an increased risk of either developing gastroparesis or of having it unmasked. We check the patient's hydration and nutritional status. In many cases, they will have evidence of dehydration and malnutrition and the succussion splash. The gold standard is 4-hour gastric scintigraphy. We can do C13-based breath tests, which is basically a radiographic compound that is digested in the small intestine, comes out of the lungs in the CO2 form, which is bound to the C13. However, it's not present universally and is mainly confined to research centers of excellence settings. Other studies, like I mentioned, ultrasonography and MRI along with SPECT can also be done. So once again, this is the studies in a list. Gastric emptying with barium, scintigraphy, ultrasonography, MRI, breath testing with the C13, testing of manometry, and ECG would be to check for, EGG, gastrogram, would be to check for the wave patterns. Requirements for the scintigraphy testing would be the patient has to fast overnight. The blood sugar should be controlled if possible, because acute hyperglycemia can also cause an element of gastroparesis, which is independent from everything that we mentioned earlier regarding the chronic etiological pathophysiology. We need to withhold agents such as opioids and benzos, which can reduce motility, and also withhold prokinetics, which can falsely mask gastric motility problems, and also stopping of anticholinergic at least 2 weeks before the testing. A solid meal is required, typically an egg white sandwich or 2 large eggs with toast, jam, and water, and at least 50% of the meal should be consumed. And even though there is not a very clear relationship between gastric motility and symptom severity, there is a classification that has been made which says mild gastric emptying is characterized by retention of more than 10%, but less than 15% of gastric contents after 4 hours. Moderate is above 15 to 35, and above 35% is severe. Below 10% is normal. I think you gathered that from how this is being described. The initial treatment, of course, very important to manage nutritional status with hydration and micronutrients, along with correction of electrolyte imbalance. Some cases which are severe require a shift to liquid enteral nutrition or even parenteral nutrition if the patient is just not able to take anything solid. We need to improve glycemic control, even though that's not necessarily a cure. We have prokinetic agents, antiemetic agents, and then other modalities. So let's speak first about dietary modifications. We need to give frequent small meals that are minimal in fat, fiber, spices, and acidity, avoiding alcohol, smoking, and carbonated beverages, as they contribute to reducing gastric motility and also to the distension symptoms. Medical therapy, oral agents, drugs. We start with either antiemetics and phenothiazine, prochlorperazine, or antihistamine, promethazine. Moving on to prokinetic agents. And some providers do it the other way around. They start with the prokinetic agents, which are a little bit more targeting of the etiology, adding the antiemetic agents as needed if that doesn't work. For the prokinetic agents, we have dopaminergic agents, which would be metoclopramide, domperidone, and then serotonergic agents with cisapride, currently not available in the US market, procalopride, and antiemetic serotonergic agents, which are ondansetron and granisetron. And then finally, a third line agent would be erythromycin. The reason for it being third line is it can cause diarrhea and bloating, along with a lot of tachyphylaxis, which is also present with metoclopramide and domperidone, but not as quickly. The main concerns with metoclopramide and domperidone are tardive dyskinesia with metoclopramide and elongated QT with domperidone, which is why they need to be monitored carefully for these. The tardive dyskinesia, which we see with metoclopramide, can manifest with either dystonia in younger patients or Parkinsonism in older patients. Finally, in addition to these two main categories of prokinetics and antiemetics, we can add what I consider to be ancillary medications such as benzodiazepines to help with the anxiety that comes with the symptomatology, and antidepressants, which help with the diagnosis itself, as well as the anxiety, the depression, and pain that can come with it. However, we should try to avoid the anticholinergic tricyclics because of their anticholinergic properties, which can exacerbate the presentation. There are other new experimental and kind of off-label treatments such as CCK antagonists, mutilides, nitric oxide donors such as sildenafil, ghrelin, and 5-HT1 agonists such as sumatriptan and buspirone. And for the pain symptoms, treatment with weak opioid receptors such as tramadol or GABA agents such as gabapentin have been shown to be helpful. We try to avoid non-steroidals for obvious reasons, and we also try to avoid stronger opioids because they can cause constipation and exacerbate the presentation. Doses here, erythromycin, all of these need to be given several times a day and are usually only given in pulse courses. We don't tend to give them for a long time because of their complications, side effects, and tachyphylaxis. So erythromycin, 3 to 4 times a day, works as a motilin agonist, can be given orally or IV, can cause diarrhea and bloating. Cisapride's been withdrawn, as I mentioned earlier. Of course, our mainstay in Bahrain, and a lot of treatment agents that we give for these conditions would be either primperan, metoclopramide, or metylium domperidone, 3 to 4 times a day. Metoclopramide can be given IV or IM, as well as being given orally. If drug therapy fails or is not sufficient, consideration can be made for botulinum toxin injection to relieve the paradoxical or unconstructive pyloric constriction that occurs, contraction. Gastric electric stimulation is also available, but it's not universally adopted. Placement of gastrostomy for relieving of pressure, as well as jejunostomy for nutritional purposes. Prior to placing a jejunostomy, of course, always best to try with an NJ tube, see if that works before moving to the actual surgical procedure. Ginger has been shown to help, and acupuncture as alternative medicine therapies. Some of these patients develop bezoars, understandably because of the stasis, and these can be dissolved or treated with cola drinks, with certain enzymatic treatment, or removed endoscopically in some cases. Here is an algorithm regarding how to manage this condition. I guess one thing which may have changed from the last time I gave this presentation is we go for endoscopy and formal diagnostic modalities earlier. But in this slide here, we can try prokinetics for a while. The patient improves, we continue doing it on a pulse basis. They don't improve, having already done the endoscopy and emptying studies along with ultrasonography. We try with higher dose therapy if no improvement, and if the patient improves, then we can maintain that. And if there's any structural problems, then we can fix those and reevaluate. I have about 2 slides left. Just to basically be clear, and this is very unfortunate, there is very little cure for this condition. It can get better after many years with good glycemic control, but it rarely goes away completely, just as is the case with, for example, diabetic neuropathy in the feet, painful diabetic neuropathy. However, improving blood sugar should help. Good news is it doesn't really affect mortality per se. 25-year mortality remains unchanged between patients with diabetic gastroparesis and nothing else. However, it does lead to poor quality of life. The bad news is there is a correlation between diabetic gastroparesis and between cardiovascular disease and retinopathy. So patients who have diabetic gastroparesis tend to have 3 times the prevalence of CV disease who are diabetic, and also retinopathy. And diabetics with gastroparesis also have a 50% higher prevalence of hypertension. In conclusion, this is a syndrome characterized by delayed gastric emptying in the absence of mechanical obstruction diagnosed formally. It is the main cause of gastroparesis, 1% more than idiopathic, as I showed you earlier, 28 to 27%. The gold standard of diagnosis is 4-hour scintigraphy showing more than 10% residual contents in the stomach. The initial treatment was with prokinetics and with antiemetics, and novel treatments can also be attempted with more radical surgical and interventional therapy reserved for advanced cases. Thank you.
Thank you, Dr. Hisham. Thank you for that insightful presentation. And I think we are on time. We will move now to the second speaker, which is the topic about the current strategy and challenges in H. pylori treatment in 2024 by Dr. Ali Al-Baggali. Dr. Ali, he's a consultant gastroenterologist at Al-Kindi Hospital, fellowship in clinical and transplant hepatology from Leonard Miller School of Medicine, University of Miami, USA, 2007. Fellowship in gastroenterology and hepatology from Leonard Miller School of Medicine, University of Miami, USA in 2006. Bachelor of General Medicine and Surgery in Cairo University in 1998. So join us to welcoming Dr. Ali Al-Baggali. Dr. Ali, floor is yours. We will leave the questions at the end of the sessions. So just feel free to write your comment or your question in the chat box.
Okay. Okay. Good afternoon, everybody. I'll just talk about the current strategies and challenges in H. pylori treatment in 2024. It's a very common subject, and we have a lot of challenges in the past, like 2 decades. So, H. pylori eradication rate failing globally, and that's because of declining triple therapy eradication rate in multiple randomized clinical trials. And there are 3 reasons. Something related to the drug, patient, or the H. pylori. And the main one is really the antimicrobial resistance. This is the main factor for failing H. pylori eradication in the past 20 years. The H. pylori antibiotic resistance, especially the clarithromycin and levofloxacin, is rising, and over the past 20 years, it rose by at least 20%.
while the resistance for amoxicillin, tetracycline, and rifabutin remains or hold strong. The resistance is only 1%. So one of the crucial medication is really clarithromycin and levofloxacin. We have a rising resistance, but the other antibiotic like amoxicillin, tetracycline, and rifabutin is still holding strong with resistance around 1% only. As you see in this table, over 20 years, the clarithromycin resistance rise from 2.9% to 18%. It is the same for levofloxacin, up to 18% increase in the resistance to H. pylori. While, as I said, tetracycline amoxicillin is still holding strong, around 1% resistant over the past 20 years. So the core principles for selecting H. pylori treatment, probably the best important point or the key point is your optimization of your first treatment or initial treatment. And that's the most important. So you have to have history. You take history from the patient. If the patient have a previous exposure to certain antibiotic, that will reduce the eradication rate. So avoid any antibiotic who already used in the past. And the other important thing, you have to study the local resistant area. If you have a resistant area for example, clarithromycin, more than 15% or levofloxacin more than 15%, you should not use this medication as the initial treatment or first line of treatment. Of course, ideally, you should do some molecular resistant testing for certain antibiotics. Optimize patient adherence, which is very important. You have to give them insight about the potential side effects. As we know, 30% of people who take concomitant therapy or bismuth quadruple therapy, they will not continue the treatment because of the potential side effect. Always treat for 14 days, never for 7 days and never for 10 days. And after treatment of H. pylori, you have to confirm eradication almost in all patients by non-serological marker, which means either by urea breath test or by stool antigen or by biopsy. You should do that at least 4 weeks after treatment, and you should not take PPI for at least 2 weeks or any type of antibiotics for 4 weeks. So these are prerequisite to do the or confirm eradication. Different guidelines for the first line of a treatment of H. pylori recommend bismuth quadruple therapy as a first line of treatment. You have the Maastricht 6 in Florence, you have the ACG guidelines and Toronto guidelines, all recommend bismuth quadruple therapy as the first line of a treatment, and we'll talk about it. You can do concomitant therapy, which is clarithromycin-based therapy, which is amoxicillin, clarithromycin, and metronidazole along with PPI. If you have a local resistant area less than 15%, which is not the case in our country. In GCC, there is at least a couple of studies regarding the resistant area of clarithromycin, one in Kuwait, one in Doha, one in Saudi Arabia. The resistant area of clarithromycin range probably 18 to 25%, it depends on the study. So we have a high resistant area, especially in the GCC in terms of levofloxacin and clarithromycin. That's why it's no more recommended as a first line of a treatment. So bismuth quadruple therapy, which we have the drug is Pylera, is basically one medication, but it contains 3 components, the metronidazole, bismuth, and tetracycline, along with PPI. Okay. Now, the pros with this medication, you have a high eradication rate. You are talking about 85 to 90%, almost 92%. And why is that? Because the main component of the drug, which is tetracycline, have a very low resistance. Even bismuth, they have very low resistance in terms for H. pylori. And it's the only drug if you have also penicillin allergy. The cons of this drug is patient adherence. You have to take 12 tablets a day, and along with PPI, so you're talking about 14 tablets a day for 14 days, and there's a lot of side effects because of this. 30% of patients who take Pylera or even concomitant therapy, they will not able to continue the treatment because of the side effect. So that's important, very important to tell the patient about a potential side effect, and he has to be aware of these side effects. You have to treat for 14 days, always for 14 days, never 7 days, never 10 days. And do not exchange doxycycline instead of tetracycline because it have a lower resistance rate. In terms of concomitant therapy, which is classed or clarithromycin-based therapy, which is amoxicillin, clarithromycin, and metronidazole, along with PPI, again, you will treat for 14 days. That should not be the primary treatment or initial or empirical treatment, at least in our area or our region, because we have higher resistance rate to clarithromycin, the local data. But it works in certain areas like North Europe, where they have a lower resistance rate of clarithromycin is than 15%. As I said, the cons is the poor eradication rate in case we have a high resistance to clarithromycin. Now, triple therapy, which is a clary-based triple therapy, is no more recommended as a first line of treatment. So you should not give a triple therapy as an empiric or first line of treatment. That's because this treatment is failed or have high rate of resistance and failure. You can give triple therapy if in areas where you have very low resistance, or you have done some molecular resistant testing by endoscopy or stool resistant for clarithromycin. Despite this, as you see here in Europe, United States, still triple therapy is the most prescribed medication or regimen for a treatment of H. pylori, which should not be the case. As I said, bismuth quadruple therapy, at least in our area, is the initial treatment or the primary treatment. So what potential option for first-line treatment to improve the eradication rate? You can do resistance-guided treatment, okay? And then, as I said, it's like molecular test, either with a stool test or endoscopy, take biopsies and we do. And it's available for mainly clarithromycin and levofloxacin. You can augment acid suppression. Very important for the regimen of H. pylori, you have to have adequate acid suppression. The more acid suppression, the more penetration of antibiotic to the bacterial cell wall. And for example, if you will give omeprazole, you have to give 40 milligrams twice a day. If you give esomeprazole, Nexium, you have to give 40 milligrams twice a day. Or you can use one of the new medication, which is called PCAB, potassium competitive acid blocker. It's a different from PPI, called vonoprazole. This drug is approved in 2015 in Japan. It works differently, I will talk about it, and have more robust and prolonged acid suppression, and that really help in terms of increasing the eradication rate. Other option is rifabutin-based triple therapy. Now, as I said, there's 3 drugs who have they have low resistance in terms of H. pylori. The tetracycline, amoxicillin, and the other one is rifabutin. So rifabutin is, if they approved in the United States, it was used to be a rescue therapy. If you failed 1 or 2 treatment, then you will give rifabutin-based therapy. Again, PPI, amoxicillin, and rifabutin have high eradication rate. Again, I will talk about it in details in the other slides. So PCAB, comparing to PPI, it's a new model, new drugs. They work differently in terms of acid suppression. Potassium competitive acid blocker versus proton pump inhibitor. The available drug is vonoprazole. As I said, it's available in Japan, in India, in Egypt, in Asia in general. It's still, I think, phase 3 trial in Europe and United States. So the PCAB, different from PPI, it binds to active and inactive. It has a longer plasma half-life and meal independent. You can, I mean, for PPI, you have to take 30 minutes before meal to have really adequate acid separation. For the BCAP, you can take it anytime. It's not related to the meal. And you see this is the Japanese data of multiple randomized clinical trials or meta-analysis of just triple therapy. Vonoprazole triple therapy, which is vonoprazole replacing the PPI, amoxicillin, and clarithromycin, all of them given for twice a day and just 7 days, which is the recommendation is 14 days. Or just PPI triple therapy, which is PPI, amoxicillin, and clarithromycin for 7 days. And you look to this, the eradication rate, you are talking about 91% with just 7 days, just by replacing the PPI into PCAP, and this is 75%. Even with the clarithromycin-resistant strain, vonoprazole, they did well, around 82% eradication comparing to 40%. So the more robust and adequate acid separation, that's why we have to give a double dose PPI during the regimen. If we available only for us just the PPI, so you have to give 40 milligram isomeprazole or omeprazole. So double dose of PPI, very important for eradication of PPI of H. pylori. So refractory H. pylori, what can we do with the refractory H. pylori? Probably the best approach for refractory H. pylori is optimization of your first line of treatment. Prevention is the best by optimization of the first line of treatment. But even if you do this, still you have 20% they will fail treatment of H. pylori. One important point, avoid antibiotic oral dependence. Once resistance, always resistance. So you cannot use the, for example, concomitant therapy, clarithromycin, flagyl, and amoxicillin. If it's failed, you cannot repeat the same regimen because it will always fail. Second line option, as I said, you can guide your treatment, especially if you fail the first line, with resistant guided treatment. It's available mostly for clarithromycin and levofloxacin. You can use the newer regimen, which is rifabutin-based therapy, to have around 85 to 92% eradication rate is a rescue therapy, or you can have a robust and adequate acid separation by doubling the dose of PPI or use the new drug, which is the BCAP, potassium competitive acid blocker. Now, very important, when you choose the antibiotic for treatment of H. pylori, you have to understand your antibiotic that you're going to use for the treatment. Now, tetracycline, amoxicillin, and rifabutin, they have a very low resistance. Only 1%, around 1%, and it's consistent. It's not rising. Amoxicillin is an important antibiotic because it's a cell wall antibiotic. It weakens the cell wall of the bacteria, facilitates subsequent penetration of antibiotic into the bacterial cell wall. So it can be reused for H. pylori because the resistance is really, really low. Now, clarithromycin and levofloxacin is a different story. They have a high resistance, and it's rising. And their resistance is absolute. Once resistant will be always resistant. So retreatment with the same regimen, it will not help and it will not get the H. pylori eradication. And the clarithromycin and levofloxacin are a game changer antibiotics. What do you mean by game changer? If you have a regimen that involves multiple antibiotics, and one of them is clarithromycin, if the clarithromycin is failed, the whole regimen will fail. Their role in the treatment is not synergistic, is a game changer. It's very important. So that's why they affect the eradication rate if there is a resistance for this component. While metronidazole, it doesn't have a game changer effect. It's just a synergistic effect. You can overcome the metronidazole resistance by the other drugs. So, but it have just a synergistic. So it does not affect the eradication rate. As I said, which is very important, you have to check for previous exposure to the antibiotic. If you use the clarithromycin if you did not use levofloxacin, you will have around 4% resistant. But if you use more than 2 courses, you have 25%, 27%. It's the same for clarithromycin. So the history is really important. The patient, he will not know really what antibiotic he used in the past, not for H. pylori in general, but you have to ask, if the patient have recurrent sinusitis, upper respiratory tract infection, tonsillitis, or probably he used quinolones or macrolide in the past, or if a female patient who have recurrent genitourinary infection, so probably she used quinolones in the past. So you have to dig more in the history to know if this patient used this antibiotic, and that will guide you to which antibiotic you will give. So there's a key question before you start in treatment. Is the patient have penicillin allergy? Now, let me tell you, 90% at least of penicillin allergy probably is not a true allergy. When you ask the patient, do you have penicillin allergy? He said, well, yeah, I have. Then when you ask, you dig more in the history, you said, well, I took augmentin and I developed diarrhea, nausea, vomiting. That's intolerance to the augmentin rather than skin rash or penicillin allergy. The other thing, if you ask the immunologist, he will tell you if the patient have mild skin reaction, and it's been long time, more than 10 years, this patient can be re-challenged with penicillin. If the patient have moderate to severe skin reaction and it's more than 10 years, he will tell you, well, we can do skin test. And if the patient have less than 10 years and severe reaction, they can do sensitization. So some patient, if you are stuck really, you need to give penicillin regimen for H. pylori treatment, you might refer them to immunologist or dermatologist to check for really if this patient have a true penicillin allergy, especially the allergy for the past long time. So as I said, salvage therapy or rescue therapy, if you fail 1 or 2, the best really is to do resistant guided checking with molecular testing. But we have a rescue therapy, which is rifabutin-based therapy. It's like Pylera, which composed from 120 milligram of omeprazole, 150 milligram of rifabutin, and 3 gram of amoxicillin. As a rescue therapy, not a primary treatment, not first line, it have around 84 to 92% eradication. So it have very low resistance, the rifabutin, 1 to 2%. It's limited availability. It's available in the United States, already approved long time ago. Most common side effect, really rash and GI side effect, but there is scary, rare side effect like myelotoxicity and ocular toxicity, though it's rare, but it can be reversible once you stop the drug. So the key points really here, bismuth quadruple therapy, at least in our area, based on the local resistance, probably the best empirical treatment option for H. pylori. It's the local resistance rather than which should be more in our practice rather than the international guidelines. Because if the guidelines then in North Europe, they have a lower resistance rate for clarithromycin. Do not repeat the same treatment regimen. Consider a previous exposure to clarithromycin levofloxacin. If you have exposure, probably don't use a regimen that contain these 2 drugs. Clary-based triple therapy is no more recommended as a treatment, at least empirically for H. pylori eradication. Always have adequate acid suppression, double dose PPI, or vonoprazole if it's available, hopefully in the future. And important, clarithromycin and levofloxacin resistance is absolute. Once resistance is always resistant. If the patient failed this regimen, you cannot repeat this regimen because he will fail the same regimen. As I said, rifabutin-based therapy carries a higher eradication rate, acceptable safety profile. Very important. You have to tell the patient about potential side effect and stress on the adherence. Your first line of the treatment, or probably the best option to get rid of H. pylori. So that's why you have to stress on adherence. You choose the right dose, right treatment, and always for 14. Always treat for no more 7 days, no more 10 days. And you can consider sensitivity, as I said, if you failed 1 or 2 treatment. Now, my slides about the treatment is finished, but I just want to stress about few points about it. Now, there are so much indication for H. pylori treatment. I mean, there's so much side effect or complication of H. pylori. Now, we know the H. pylori can cause gastritis, which is mild, moderate, severe. It can cause ulceration, duodenal ulcer, gastric ulcer. It can cause mild lymphoma. It can cause signature ring carcinoma, adenocarcinoma. So it's a precancerous. And it can cause extra-intestinal manifestation like iron deficiency anemia, B12 deficiency, urticaria, ITB, rosacea, and so on, some dermatological diseases. Now, but 50% globally infected with H. pylori, and more than 80% they are asymptomatic. They don't have symptoms. So at least in Bahrain, for example, if you see 10 patients who come with dyspeptic symptoms, upper GI symptoms, at least 4, which is 40%, they will have H. pylori positive. So it's very, very common now. Does getting rid of H. pylori have a consequence or side effects or complication? Now, a few years ago, in Japan, the healthcare system of Japan, they went into a village, not in Japan, in China, they went into a village and they empirically treat all these people in the village for H. pylori treatment. Empirically, they just treat them. Now, they visit the same village after 2 years and they found most of them, they become obese. So we don't know, is this because change in the gut microbiota, because of the H. pylori? It's just because their symptoms improve because they have dyspepsia and so on, and their symptoms improve and they become eating. So we don't know really eradication of H. pylori would have a long-standing risk on our health. But we know that especially those who have H. pylori infected in the corpus, they might develop GERD, more acid reflux, more bad after eradication of H. pylori. It's linked to childhood asthma. Now, more that about inflammatory bowel disease, obesity, metabolic syndrome, and so on. And as you see here, there is an inverse correlation between the prevalence of H. pylori and inflammatory bowel disease. Areas where we have very high prevalence of H. pylori, we have a lower prevalence of inflammatory bowel disease, and vice versa. Those who have a lower prevalence of H. pylori, they have high prevalence of IBD. And with the discovery of the first ulcerative colitis in China in 1956, that was associated with gradual drop in the H. pylori. And we don't know, is this just a statistical coincidence, epidemiological coincidence, or because of eradication of H. pylori that changed the gut microbiota and lead to more inflammatory bowel disease in this population? As we know, in Bahrain, in Asia in general, Bahrain, India, over the past 20 years, the inflammatory bowel disease have increased dramatically. And of course, H. pylori has decreased. So we don't know whether there is a link between these two events. But what we know, we have a disease trend after H. pylori eradication. This is a Japan nationwide claim and health check up database. And it's around 5.2 million. They found that patient after eradication of H. pylori, the prevalence of Crohn's disease at least below the age of 60 is increased. When you get rid of H. pylori, ulcerative colitis will increase. The prevalence of ulcerative colitis will increase. And it's the same for allergic disease, it's the same for obesity and metabolic disease. Certainly, we need much more data, much more studies, okay, to see if there is a correlation between eradication of H. pylori and these events. So I think I will stop here and thank you very much.
Thank you, Dr. Ali, for this insightful presentation. So now anyone having any question, just add it to the chat box. We have one question from Dr. Zahra Khalifa. She's asking, Dr. Ali, does probiotic has any role in eradicating H. pylori?
Okay, so initial guidelines, we used to give a probiotic along with antibiotic regimen for eradication of H. pylori. But subsequent guidelines, they don't recommend to give probiotics. And we give the probiotic is not just because it helps in eradication rather than antagonize the effect of multiple antibiotic on the gut microbiota.
Thank you. Any questions?
Dr. Ali, Doctor.
Dr.
Dr. Ghazi.
Hello.
Yes. Yes,
Hello,
Dr.
hello.
دكتور غازي البحروس.
اهلا وسهلا دكتور، شلونك؟
اهلين. انا بس يعني اولا الريزيستنت باين منتشره في البحرين وتحتاج الى public awareness وتحتاج الى government movement to improve it. بعدين الشيء الثاني حسب ما يبدو البي بي اي يعني يشغلها انه يعني I read a report that it will suppress the nitrous oxide. Okay, so a patient with ischemic heart disease, okay, and you give him PPI, you know, it seems to be somewhat dangerous. And the microbiota story is a very strange, you know, it will eradicate most of the bacteria in the large intestine. And you're talking about that it will increase obesity. I have no idea how it happened, you know. But I think, I don't know whether we'll find sometimes in the future a new treatment for the H. pylori or not, you know. But certainly it's something really worrying, especially the resistance. Would you comment on this?
Yes, your first point is the resistance is rising because we really have a problem with the antibiotic use. Like, for example, 90% of gastroenteritis, they are viral gastroenteritis. But every patient comes to my clinic who had gastroenteritis already received antibiotics. So we have to have really more restriction on the antibiotic, which I think it's very important. It's not only H. pylori, it's other resistance, other infection, which is sometimes more crucial. Now, if you give antibiotic like for H. pylori or different antibiotic, true, the gut microbiota might change, but even if you change your gut microbiota, it might take a few months, and again, it will come back to your baseline gut microbiota. And talking about gut microbiota, which is very important, and I think it's going to be linked to a lot of disease in the future, obesity, diabetes, and so on, cancer, even inflammatory bowel disease. Now, because our diet changed in the past 20 years, okay, that's really make things more difficult. If you change your diet, you will change your gut microbiota. And your gut microbiota might keep you healthy or unhealthy. It depends on what you change your diet. If you change your diet more like they call Mediterranean diet, more fiber, more vegetables, more fruit, and so on, okay, you will change your gut microbiota. And if you change your gut microbiota, you will become healthy. If you have a bad microbiota, you will become unhealthy. I agree with you, Doctor.
Thank you, Dr. Ali. And as we wrap up this session, I would like to thank all our speakers for their enlightenment presentations and the audience for their engaging questions. Enjoy the rest of your day at the IMDO 6 conference, and we will move now to the second session. Thank you so much.
Thank you, Dr.
Rabia.
for sharing this session.
Thank you.
And your participation is really appreciated.
Thank you.
So, good afternoon. You can see the slide here clear. Hello?
It's clear, Dr.
Yeah,
Hassan.
clear.
Yes. So good afternoon, ladies and gentlemen. This lecture is supposed to be given by really one of our colleagues, but unfortunately they cannot give it. So I will present the same lecture about gestational diabetes. So first of all, gestational diabetes defined as any degree of glucose intolerance onset of first recognition during pregnancy, while it affects 2 to 10% pregnancy in the United States. Recently, we get new data that 1 of 6. Hello? Recently, even 1 in 6 patients have developed gestational diabetes. Women with gestational diabetes have 35 to 60% chance of developing diabetes, while again, maternal complications consist of hypertension, preeclampsia, increased risk of the cesarean delivery and development of diabetes after pregnancy. Fetal complications include macrosomia, neonatal hypoglycemia, polycythemia, increased perinatal mortality, congenital malformation, and we can just stress that polycythemia can cause the hyperbilirubinemia, of course, with respiratory distress syndrome and hypercalcemia. Long-term consequences of macrosomia include increased risk of glucose intolerance, diabetes, and obesity in childhood. The Australian carbohydrate intolerance study in pregnant women was a large randomized control trial that investigated the role of screening and the treatment of gestational diabetes, reducing prenatal complications, improving maternal outcomes, and affecting quality of life. So trials conducted in the United States recruited women with the mild gestational diabetes mellitus.
Sorry, Doctor.
Another large one group received treatment consists of dietary changes, self-monitoring of blood glucose and insulin if needed, and other received by usual prenatal care. Outcomes with respect to prenatal and obstetrical outcomes were compared. The trial of about 20,000 participants used slightly different parameters to diagnose gestational diabetes, but had similar outcomes. There was a significant reduction in macrosomia with the treatment group, as well as a reduction in the rate of cesarean delivery, shoulder dystocia, preeclampsia. HAPO trial, hyperglycemia and adverse pregnancy outcome, which included over 23,000 pregnant women. So to clarify risk of adverse outcomes associated with various degree of maternal glucose intolerance, less severe than other diabetes mellitus. The study results show positive linear correlation between increasing levels of fasting 1 hour and 2 hours plasma glucose after a oral glucose tolerance test and macrosomia and cord blood C-peptide levels above the 90th percentile. Weaker association were noted between glucose level and cesarean delivery and neonatal hypoglycemia. The secondary outcomes of premature delivery, shoulder dystocia, hyperbilirubinemia, and preeclampsia were also noted to increase in the incidence with higher level of post-OGTT glucose level. Diabetes screening was based on risk stratifications. Well, now to have the ADA recommend that all women with no prior history of diabetes undergo 75-gram glucose oral glucose tolerance test at the 24 and 28 weeks. Further than this, there is 3 studies being done. One of them, it is one Indian study, beside one Israeli studies of about 6,000 pregnant. They start to do checking glucose even in 20 weeks, and the other one even 9 weeks earlier, and they find results which can be correlated that treatment and diagnosis early in a pregnancy can change the increment of the weight of macrosomia. So earlier than 20 weeks, and even 9.5 weeks also can be done in the new studies being published recently and supported by many like ADA and other institutions, except National Health and also WHO, because of the cost had been adding for doing and implicate this test to be done earlier. While we suggest that this test to be done earlier in cases of high-risk patients rather than the usual risk, and this will be also depends on the country you are working on. 75 gram 2 hours OGTT is the test of choice in both groups. Women at high risk for gestational diabetes are screened at the first prenatal visit. Increased weight, BMI greater than or equal to 25, decreased physical activity, first degree relative with diabetes, member of ethnic group with high prevalence of diabetes, African American, Latin, Native American, Asian American, Pacific Island, and prior history of gestational diabetes or delivery of a baby greater than 9 pounds. Metabolic abnormalities, hypertension, HDL cholesterol less than 35, triglyceride level greater than 250 milligram, polycystic ovary syndrome, and HbA1c 5.7 or higher, impaired glucose tolerance or impaired fasting glucose testing, and is past evidence of insulin resistance, like signs of acanthosis, nigricans, or severe obesity. Well, the 75 gram glucose OGTT is the best performed after an overnight fast. Diagnosis is made if the fasting plasma glucose documented at 92 milligram or higher, 1 hour glucose of 180 or higher, or 2 hours plasma glucose of 153 or higher. The diagnosis is confirmed with a minimum of 1 or abnormal value. So 1 abnormal value will help you to get the diagnosis. So there is a new studies showing that if your fasting blood sugar of 5.1 also, it can indicate a gestational diabetes, but there is a lot of studies to do pre-analytical assessment because of this being many institutions worried about that overdiagnosis of the gestational diabetes. So diabetes mellitus diagnosis, and this is with the HbA1c above 6.5, fasting plasma glucose above 26, and 2 hours plasma glucose 200 or higher during, and 75 gram OGTT, and when symptomatic patient with random plasma glucose of 200 or higher. So 2 major changes from the guidelines are lower diagnostic cut points, as we explained, the implications of increased healthcare also costs, also the intensity of monitoring and treating these women, well, still of the maternal and neonatal outcomes. So HAPO study, which was on 26,000, changed a lot of things for the criteria of diagnosis. American College of Obstetricians and Gynecologists, comparatively, well, has not adopted the IDPSG and ADA guidelines, gestational diabetes protocol, and the most recent committee opinion. Well, diagnosis of gestational diabetes continue to be based on the 100 gram 3 hours tolerance of using Carpenter and Costin cutoff of fasting less than 95. So fasting of 95 or higher, 5.1 1 hour, or 180 or higher, 10 millimole or 153 or higher is 8.5. As stated above, diagnosis of gestational diabetes made if any of the following values are exceeded after 75 gram glucose is given. Following delivery, patients should be screened for persistent diabetes 6 to 12 weeks postpartum, as an increased risk of developing type 2 diabetes type 1 diabetes, and cardiovascular disease exist. Following that, these patients should have lifelong screening for pre-diabetes or diabetes development every 3 years. Before we go in details, before the classification even now had been changed for the diabetes. So that is what we call it DIP, diabetes in pregnancy and over diabetes. We have also the what we call it gestational diabetes, which is the classical one, and early gestational diabetes, which is the one what we suggested being done by the many studies, like doing the glucose within the period of 20 weeks, or even in some studies they conducted in 10 weeks, high resolution. So pharmacologic therapy, an elevated blood glucose level despite lifestyle modification is an indication for pharmacologic therapy, although insulin has historically been standard therapy for women with uncontrolled gestational diabetes. Oral medications are now appropriate first-line therapy as well. Options for oral medication include metformin, glucophage, and glyburide, although neither glyburide nor metformin has been approved for administration, but both are a pregnancy category B. So metformin and glyburide cross the placenta, but have not been associated with birth defect or short-term adverse neonatal outcomes. However, data for on long-term metabolic effects on children with the in utero exposures are limited. Clinicians may consider counseling patients on the back of long-term safety data for these medications. Indications: gestational age, frequency, and severity of blood glucose elevations, fetal growth, and patient preference. Well, one approach is to begin pharmacologic therapy if more than 2 values at the same meal during the 2 weeks period are above target by more than 10 milligram per deciliter. So what is this? We can equivalent to 0.6 millimole per liter. Another approach is to initiate medication if 50% of the value in a given week are elevated. We can use regularly now. Also, we are using the Libris system or CGM also to check the increment of the level, and easily can also pick up the control, whether being done or the target achieved or not. So glycemic control, maternal and neonatal outcomes and adverse effects are similar among patients treated with oral hypoglycemic medication, insulin, although glyburide may be associated with a lower failure rate. That is to say, need for insulin therapy than metformin. So the failure in the glyburide arm was more. Metformin is typically started at 500 milligram once daily with the food and titrated to maximum dosage of 2,500 milligram per day, given in divided doses with the meals. Glyburide is initiated of 2.5 milligram once per day, 1 hour before eating, and increased to a maximum of 10 milligram twice per day, as needed between the 15 and 40% of women initially prescribed oral medication for the gestational diabetes mellitus Leishman. So basically, general practitioner and gynecologist, obstetrician with the endocrinologist, with this multidisciplinary team, try to achieve the target of the really difficult fasting and the postprandial with the HbA1c average glucose for pregnant ladies. So insulin is required in women who have uncontrolled blood glucose levels despite lifestyle changes and use of oral medications, and in women who elect to avoid a trial of oral medications, insulin doses, insulin does not cross the placenta. Rapid, intermediate, and long-acting insulins are considered safe for use in a pregnancy. And Professor Abdel Mohsen, he talked in details about type of insulins and how to use it according to the duration of action, whether short-acting or long-acting. One approach to start insulin therapy is to calculate a total daily dose of 0.7 to 1 unit per kg. If we say that a patient with 70 kilogram, so she will need between 40 to 70 units per day. Half of this dose requirement is administered a single dose, long-acting insulin. So we can say half of it, like 30 long-acting, and the remaining will be divided according to the meals in 3 divided doses. So 0.7 to 1 unit per kg measurement. You can just adjust the dose accordingly according to the fasting and postprandial sugar. But unfortunately, I saw a lot of very minimal doses of insulin and keep the patient for 2-3 weeks just on small doses of insulin. This would not succeed to control sugar in a pregnancy. This algorithm for the management of gestational diabetes, well, of course, we can look for the HbA1c, and we can look for the other parameters. So if there is risk for pre-existing diabetes, then screen using the fasting glucose level, HbA1c level, or the 2 hours oral glucose tolerance test. If no, then we go to screen at 24 to 28 weeks for gestational diabetes. So this is what we stressed on, that high risk or low risk, or what we can say the early detection for the gestational diabetes. If it is abnormal, then manage as the pre-existing diabetes. If it is normal, so routine care. If it is abnormal, then begin blood glucose self-monitoring, lifestyle modifications, and the close follow-up. Then glucose level fasting below 95, which is 5.3, 1 hour postprandial below 140, and 2 hours below 120. Usually we do measure 1 hour, but we give the chance to the patients to measure after 2 hours. So if it is not controlled, then consider initiation of oral agents or insulin, follow up in 1 or 2 weeks. And then if it is yes, continue monitoring. If the glucose controlled, then we continue on the present management. And if it is not, then we consider antenatal testing at 32 to 34 weeks. If it is not controlled and above, we plan for delivery at more than 39 weeks. Then estimated total weight above 4.5. If it is yes, cancel potential risk and benefits for subsequent cesarean delivery. So fetal surveillance in a pregnancy complicated by gestational diabetes, antenatal testing in women who have gestational diabetes that is well controlled without medications is not beneficial because the risk of stillbirth is not increased in this population. Antenatal testing is commonly performed in women who require medication for gestational diabetes, although data supporting this practice are limited to older observational study. The American College of Obstetricians and Gynecologists recommends that clinicians perform antenatal testing in accordance with the local practice patterns. Such testing could include a twice weekly non-stress test or weekly modified biophysical profile beginning at 32 to 34 weeks of gestation. Well, the timing and route of delivery. The optimal timing of delivery in a pregnancy is complicated by gestational diabetes is unclear, given the neonatal risk associated with early term birth. Induction of labor before 39 weeks should occur only if glycemic control remains poor, despite medication use, or if another indication for delivery is present. Limited evidence suggests that induction of women with gestational diabetes at 39 weeks compared with further expectant management is associated with a lower risk of macrosomia and shoulder dystocia without increasing the risk of cesarean delivery. Expectant management beyond 39 weeks is also associated with an increased risk of stillbirth, 1.8 relative risk, and absolute risk remain low, which is 5.7 per 10,000 delivery. Although ACOG has not made an evidence-based recommendations on the ideal timing of delivery for patients with gestational diabetes, many physicians offer induction between 39 and 40 weeks, particularly for patients with other risk for stillbirth. For women with gestational diabetes and an estimated fetal weight greater than 4.5 grams, scheduled cesarean delivery compared with the vaginal birth reduces the risk of permanent brachial plexus injury. Although number needed to be treated may be as high as 588, it's reasonable to offer a scheduled cesarean to these patients, although they should be counseled on the difficulty of accurately estimating fetal weights and risk associated with cesarean delivery in the index pregnancy and the future pregnancies. Intrapartum and postpartum management, maintaining euglycemia during labor and delivery can minimize risk of neonatal hypoglycemia and acidosis. Women with diet control, gestational diabetes rarely require intrapartum insulin. A variety of protocols exist to guide intrapartum management of blood glucose among women receiving insulin, but in general, glucose level should be monitored every 1 to 2 hours during active labor, and 5% dextrose or insulin infused as needed to maintain a glucose level between 70 and 110 milligram per deciliter, 3.9 and 6 millimole per liter. Well, this is very important to keep the patient intrapartum on insulin infusion on one side and the fluid infusion pump on the other side, and check the sugar every 2 hours. So it may be reasonable to have women with gestational diabetes on only 1/2 of their usual dose of long-acting insulin in the day of delivery, and this is what we recommend. A clinician should prepare to manage shoulder dystocia at the time of delivery and exercise caution when considering an operative vaginal delivery. After delivery, women with gestational diabetes should undergo a screening at 6 to 12 weeks postpartum with a fasting glucose measurement or 75 gram 2-hour glucose tolerance test. Up to 36% of women with gestational diabetes may have persistently abnormal glucose tolerance. Women with a history of gestational diabetes should be screened every 3 years for overt diabetes. And this is very important to check the sugar. And I have a lot of patients in the history that they mentioned that they have gestational diabetes, as we explained earlier. Breastfeeding may reduce the subsequent risk of developing type 2 diabetes in women who had gestational diabetes. Any form of contraception that is otherwise medically appropriate can be used by women with a history of gestational diabetes. Antenatal corticosteroid therapy in day 1. So for lung maturation, gynecologist and physician, they give corticosteroids. So on that day 1, we'll increase the night insulin dose by 25%. The day 2 and the 3 increase all insulin doses by 40%. Day 4 increase all insulin doses by 20%. Day 5 increase all insulin doses by 10 to 20%, while day 6 and 7 gradually taper insulin doses to pre-betamethasone or dexamethasone doses. If not previously done in women with the threatened preterm labor requiring betamethasone, a screening and diagnostic test for gestational diabetes should be performed either before or at least 7 days after the administration of betamethasone. Breastfeeding, we mentioned this. And by this, I try just to summarize that gestation diabetes associated with a number of maternal complications, preeclampsia, polyhydramnios, prolonged labor, obstructed labor, and gestation diabetes also increase the risk for type 2 diabetes in both mother and child. By this, I end my lecture and thank you for your listening.
Thank you, Dr. Asad, for your presentation. On behalf of Dr. Anne, there is one question in the Q&A, if you don't mind.
Okay. Well, I cannot see it. You can read it for me, please.
Dr. Asad?
Yeah, I cannot see the question.
The question, okay. Duration of lifestyle before starting medication.
Okay. Well, it is for me and or also for guidelines, lifestyle modifications. We should stress on that point that patients, if you start earlier than the 20 weeks or well, a lot of studies have been recently published that stress on doing the preparation of the patient with the risk of diabetes or gestational diabetes many months even before becoming pregnant. So what I do suggest for my patients who have risk of becoming patient with gestational diabetes or becoming pregnant, well, they have obesity or previous history, as we mentioned in the lecture. They have baby with more than 9 pounds and 4.5 grams. All of them, I suggest to them to start lifestyle even before becoming pregnant. And for me, I don't give long time to control the sugar with the lifestyle during gestational diabetes. So for me, I start with the metformin with the lifestyle. I give chance for a couple of weeks. And then if there is a clear indication for insulin, even with big baby, earlier we start them on insulin. So basically, what you need to keep the optimal glucose control, and it is very difficult for the ladies to control it without doing diet control. So we engage the dietitian, education nurse also, and as a team, of course, the obstetrician also giving advice. We try to keep the achievement of the fasting glucose below 90 and the postprandial 1 hour below 140 or 2 hours below 120.
Okay, Dr. Asad, maybe Dr. Salam Jibril would like to share his experience.
Yes,
Dr.
sure.
Salam, tfaddal.
Thank you, Dr. Asad. It was a lovely presentation. And one point I want to emphasize to all that this is a teamwork. It's the gynecologist, the obstetrician, and the diabetologist, the internist, and the primary care physician to have an integrated work. All of them should take care of this patient who is having gestational diabetes, especially those who are found to be having gestational diabetes for the first time. Education is the very most important, and at least they should visit their diabetologist at least once. This is very important. We shouldn't rely on our good experience as a way to treat those patients. The second point is the timing of the glucose tolerance. I have heard in all conferences I have attended that it should be 24 weeks and above, not earlier than that. Those who have diabetes before can do the test, the diabetic 3 hours screening earlier. But those who are having gestational diabetes or those who want to have the screening test, it should be above the 24 weeks gestation. Thank you again. It was a lovely lecture. I enjoyed it.
Thank you, Professor Salam, for your comment. And really, I agree with you that this is a teamwork, and the obstetrician, beside the nurses, education, nurse, and dietitian, all this team can be succeed to manage these cases. So, Dr. Ghazi, if you can introduce Dr. Jamil is here.
Okay. Yeah. Just 1 second.
He's on the screen, Dr. Ghazi, if you want. Hello, everybody. I would like to introduce Dr. Jamil Al-Mouzan. He's a consultant radiologist, head of radiology department at Gulf Diabetes and Medical Specialist Center here in Bahrain. And he has been a speaker at multiple national and international conferences, and he has been with us for the past 5 IMDOs. Okay, Dr. Jamil, the floor is yours. You are okay?
Thank you, Dr. Iman. Thank you so much for this presentation. And I am happy I am with you for the 5th time in this conference. And I tried to make this presentation as digestive as possible. As you know, it is now the time for lunch. A welcome for my colleagues who are online now. I try to make this imaging of non-alcoholic fatty liver disease as simple as possible for all our colleagues. Now, non-alcoholic fatty liver disease is defined by the presence of hepatic fat. Dr. Iman, you hear me?
Yes, Dr. Jamil, loud and clear.
Okay, okay. Non-alcoholic fatty liver disease, by definition, is defined by the presence of hepatic fat content, steatosis, in 5% or more than that in hepatocytes in the absence of specific causes, such as viral hepatitis, alcohol abuse, steatogenic medications, or genetic lipodystrophies. It is the most prevalent chronic liver disease in the world, with approximate worldwide prevalence of 25% in non-diabetics and 70% in diabetic patients. Severity range from non-alcoholic fatty liver, which is an isolated steatosis, they consider it not so dangerous, to non-alcoholic steatohepatitis, where half of patients will evolve to fibrosis, 10 to 15% to carcinoma, and 5.4% to hepatic insufficiency, which is on the more severe end of spectrum in different studies. In fact, liver biopsy remains the gold standard for diagnosis of non-alcoholic fatty liver disease. And it is still needed for the conclusive diagnosis of non-alcoholic fatty steatohepatitis and to differentiate it from isolated steatosis. But there is some limitations in liver biopsy. It is high cost, sampling inaccuracy, invasiveness, leading to pain, infection, bleeding, limited patient acceptance, low intra or inter-observer repeatability, and due to heterogeneous distribution of fat in the liver, sampling error frequently occurs. That is why it is considered impractical in routine and repeated steatosis assessment. And that is why several imaging techniques and strategies of ultrasound, CT scan, and MRI for a quantitative evaluation of hepatic steatosis have been improved instead of biopsy. In fact, ultrasonography is the key imaging modality in evaluating hepatic steatosis. It is widely available worldwide. No radiation exposure, echo change in hepatic parenchyma. Its picture really is as simple as that: echo change in hepatic parenchyma as a diffuse increase in hepatic parenchymal echogenicity. It is either categorized as or graded either absent or mild or moderate or severe hepatic steatosis. The absent one, you will see the liver and renal cortex, as in this case. The liver and renal cortex are of similar echogenicity, and normal echogenic walls of the portal and hepatic veins, with the clear appearance of diaphragm. And if you notice that the liver proximal to the transducer, echo texture is the same as that of distal part of liver. And all these are seen in the mild case, apart from that echogenicity of liver is much higher than the echogenicity of cortex of kidney. In moderate, we see diffuse increase hepatic echogenicity, obscuring the peripheral echogenicity of preportal veins and the hepatic veins, but the diaphragm can be seen, and the echo texture of distal part of liver is still the same as the proximal part near the transducer. But in the severe type, diffuse increase hepatic echogenicity, as you see in this case, obscuring periportal as well as diaphragmatic echogenicity, and the distal part echogenicity is not the same as the proximal part of liver. But there is limitation, of course, for ultrasound. B-mode ultrasound is a subjective examination, strongly operator dependent and platform dependent. Ultrasound can offer reasonable accuracy in detecting moderate to severe hepatic steatosis. In some studies, they say that up to 90%, but it is much more inaccurate in detecting mild cases down to 50%. The first quantitative ultrasound was considered as semi-quantitative. In fact, it is the hepatorenal index. Hepatorenal index is the ratio of echo intensities of the liver, parenchyma, and renal cortex, as you see in this case. But a significant variability noted because it is affected by operators' experience, depth of measurements, and variability of different manufacturers for calculating this measurement. It is impossible to have same finding and same numbers in different modalities and different places. So quantitative ultrasound, they try to make it more accurate based on estimation of attenuation coefficient, which measure the loss of ultrasound energy in the tissue, and backscatter coefficient, which measure ultrasound energy return from the tissue and speed of ultrasound through different component of tissue. But the There is limitation, of course, still not solved. The use of a quantitative ultrasound methods for the assessment of liver fat content is promising. However, more studies are needed to understand the confounding factors and to best optimize protocols and mitigate them. In computed tomography, we depend on X-ray absorption of the fatty tissue, which is less than that of normal hepatic tissue in the fatty liver. Normal liver parenchyma density is about 60 Hounsfield units in an enhanced CT, which is higher than that of spleen, which is 50 Hounsfield units density, and it is reversed when we have fatty liver. But superimposed iron, iodine contrast, and hepatitis can increase liver attenuation and may appear like a mask, or mask the already existing steatosis. That is why they try in the dual energy CT, which utilizes two X-ray spectra of high and low energy in the image acquisition process, may differentiate between many chemical composition inside tissue, including fat, and it is superior in diagnostic performance for detecting hepatic steatosis. Distinguish between superimposed iodine or iron overload. There is limitation, of course, for CT scan, including ionizing radiation, variations between scanners, manufacturers, and reconstruction algorithms make follow-up very difficult. The spleen, in fact, is an imperfect reference standard, as it can be affected by hemosiderosis and hemochromatosis in a small minority of patients. For the future directions, there is further advancement of spectral CT or dual energy CT, the same technology in proton counting CT, which is useful for precise measurement in monitoring hepatic steatosis. In fact, automatic assessment of CT liver Hounsfield values has been developed for liver fat quantification by deep learning based on artificial intelligence, and complete automatic liver segmentation can improve reproducibility and objectivity, which can avoid human bias. We finish with a CT scan revision, but magnetic resonance imaging, in fact, which use 3 ways for measurement of fat in the liver, including conventional chemical shift image, MRI spectroscopy, and chemical shifted encoded MRI. In fact, MRI technique exploit the different reasonable frequency between proton in fat, acid molecules, and protons in water molecules. In phase and out of phase gradient eco-breath-hold image can show us the difference between the two. The degree of signal loss of hepatic parenchyma in out-of-phase image induce the fatty deposition. There is limitations, of course, and suitable for quantitative evaluation due to multiple confounding variables. MRI spectroscopy is capable of detecting even small amounts of intrahepatic lipid accumulation by estimating proton signals of water and fat as separate peaks acquired during a single breath hold, approximately 15 to 20 seconds. And chemical shift encoded MRI take advantage of a chemical shift in resonance frequencies between fat and water. A proton density fat fraction is a fat percentage. So it is like the histopathology examination, where it's ranging from 0 to 100% fat saturation of hepatocytes. This is example of MRI proton density fat fraction fat map and corresponding MR spectroscopy showing severe case of fat deposition or fatty liver. We finished the first part of our lecture, which is about the modalities which we diagnosed by it, the fatty liver disease. But the second part is the imaging picture, the imaging patterns which we see these diseases, which is very important because some unusual focal forms may be misdiagnosed as infiltrative or nodular liver lesions. It is therefore important for radiologists to be aware of patterns of heterogeneous or focal forms of fatty deposition. It is either diffuse, we spoke about it, most of image and ultrasound, and can be geographic deposition, can be focal, subcapsular, multifocal, and perivascular. Each one will show its picture. As you see here, the ultrasound is showing severe fatty liver deposition in comparison with the cortex. And as we said, the blood vessels and diaphragm are obliterated. This is the CT scan. If you see the density here of the liver is less than that of the spleen, while in the normal, it must be a little bit higher than that of spleen. In MRI, in-face image showing the diffuse liver hyperintensity and the diffuse clear fall in the signal of intensity of the liver in out of phase or fast suppression. It is the most prevalent form of fatty liver disease. Some studies say that 85%. The liver is homogeneously involved by fat accumulation, as we said. While in geographic fat distribution, it is frequently encountered variant, sometimes occur only in the right liver lobe. If you see, this is the liver, normal liver texture or density. In fact, this is CT scan, and this is the fat accumulated geographical distribution, the same for the same patient in the ultrasound. And by MRI, if you see, it is ISO intense on in phase, but on out of phase or fat suppression, you see the demarcation between the fatty liver and the normal part of liver, giving this geographic fat deposition. The other one, which is very important, it is slightly less common, but it can mimic other hepatic benign or malignant lesions. MRI is very useful for diagnosis of focal hepatic steatosis, which appears ISO intense or hyperintense to liver on in-face image and loss signal on out of face image or fat suppression. This is example for focal fat deposition. You see in the CT scan, this area, wedge shape, which look like in the right liver lobe, which look like as if it is metastatic lesion or hepatoma. By MRI, this appeared because ISO intense to the other liver parenchyma, but very clear fall in signal, leading to hypointense in comparison to the other liver. That means this is mainly fat deposition. And we spoke about fat deposition. Now fat sparing. The liver involved in fat, but there is areas like this one and this one and this one are not involved. It is fat spared. By CT scan, you see the liver intensity, the density is less than that of spleen, apart from this area of fat spared area, as you see. By MRI, it's also here iso-intense, but you see it is hyper intense to other liver, which is involved in fat, and these are fat spared areas. There is subcapsular fat deposition, which is in fact rare form of patterns present as a small fat nodules, as these are by CT scan, confined to the subcapsular zone, and it is maybe idiopathic. Here, it is maybe a little bit hyper intense on in phase, and on fat suppression or out of phase, it is low intense, as you see here. This is very rare, which is multifocal fat deposition, multinodular hepatic steatosis, some literature say. It can represent a difficult diagnosis challenge. Multiple fat foci are randomly distributed throughout the liver. The foci are usually round or oval and might make multiple nodules, as in this ultrasound. And this is the CT scan of the same patient. And the differential diagnosis, in fact, is a wide subject for differential diagnosis for such a case: metastasis, lymphoma, sarcoidosis, abscesses, candidiasis, hemangiomatosis, and biliary hamartomas. And in fact, this is by CT scan, out of phase, in phase image showing about to be iso-intense to the other liver parenchyma. On out of phase, you see these densities proving that it is fat mainly. The last pattern is the perivascular fat deposition and perivascular fat sparing. It is very unusual pattern. Halos of fat or halo here is spared area around the portal, hepatic and portal vein. It may be difficult differentiated from periportal edema, passive hepatitis, congestion, and Budd-Chiari syndrome on CT and ultrasound. This is another case, not the same, with the MRI in phase. Look to the hyper intense lesions in comparison with other part of the liver, which go to be hypo-intense on out of phase image. In conclusion, liver biopsy remains the gold standard for the diagnosis of non-alcoholic fatty liver disease. Conventional ultrasound is the key imaging modality in evaluating hepatic steatosis. Several quantitative imaging modalities have been improved instead of biopsy, which has its own limitations. Each method of imaging has benefits and drawbacks. MRI, proton density, fat fraction has been considered as the best technique among all methods, and even better than outperforms a biopsy. Some unusual focal forms may be misdiagnosed as infiltrative or nodular liver lesion, so it is important for radiologists to be aware of patterns of heterogeneous or focal forms of fatty deposition. Thank you, and this is the Mutanabbi Street in Baghdad, where you can find books offered like fruits. Thank you so much.
Thank you, Dr. Jamil, for a nice presentation. And really, fatty liver, it's a bigger problem. I think Dr. Ghazi has a comment about that.
Oh, thank you very much, Doctor.
Thank you. Welcome. Welcome, Dr. Ghazi.
I think, you know, from the medical point of view, it's
Yeah.
the most dangerous presentations, you know, of this fatty liver. And I
Yeah.
think the culprit and the main cause for it is the soft drink, especially fructose. Fructose only metabolized by the liver. Okay? And most of it, you know, if it increase, it change to fatty liver. And fatty liver change after that fibrosis. So I think, you know, if you want to prevent fatty liver, prevent soft drink.
It is your job, not my job. I diagnose it only.
Yes. Okay.
I give the diagnosis only. Thank you.
I have a question, Dr. Jamil, for the role for the being DIXA scan showing also for the body fat composition being mentioned also by our colleagues in the obesity. So is there any procedure other than MRI and ultrasound to help? Like we can hear about ultrasound fibroscan and any like radiological let's say radio tracer to help in diagnosis of the fatty liver.
Fatty liver, yes. If you go to literature, you will find some mention the X-rays also. Some the conventional X-ray will appear the liver less density than other organs, but these are from history. In fact, the tracing and the most important are ultrasound and CT scan and MRI. For elastography, you mentioned ultrasound, it's diagnosing fibrosis and not fatty liver, in fact. But in the future, I think artificial intelligence will play very, very big role in diagnosis of fatty liver and follow-up. Thank you for the question.
Thank you, Dr. Jamil. Dr. Iman?
Yes, I'm sharing the bio of Dr. Rabia, which gives me great pleasure to introduce him. And inshallah, Dr. Rabia, for next IMDO, you'll be here with us. So I would like to introduce Dr. Rabia to everybody. He's a urologic oncologist with 15 years of academic and clinical experience in urologic oncology and minimally invasive surgery. He was the director of robotic surgery at Case Western Reserve in Cleveland, USA, before moving to Georgia, USA, and heading the urologic oncology and robotic surgery programs at Augusta University Health for 9 years. Dr. Rabia Madi is among the most experienced robotic surgeons in the USA. He has performed more than 2,300 robotic surgeries and counting, I guess, and has more than 50 peer-reviewed publications and 120 presentations in national and international meetings. Dr. Rabia has pioneered new techniques and approaches in urologic oncology and robotic surgery. And Dr. Rabia is considered one of the best urologists in Dubai and the wider Gulf region. Ahla wa sahla, Dr. Rabia, we're happy to have you. You can share your slides whenever you are ready.
Welcome, Dr. Rabia, to our guest speakers. Thank you for participating in the conference.
Thank you very much for the invitation, Dr. Asad and Dr. Iman. I'm very honored to be here, and hopefully in the future meeting I can be in person presenting with you. I'm not sure whether you can see my screen today.
Put it on slideshow, please. It's clear.
Okay. All right, so good afternoon, everyone from Dubai. My name is Rabia Madi, so I'm a urologist at Clemenceau Medical Center Hospital in Dubai. I moved to Dubai 3 years ago, and I'm really happy here. So today, I'm going to talk to you about adrenalectomy. So I will start initially by some background about incidental adrenal tumors, and then I'm going to share with you a video of my surgery in removing the adrenal. So first, briefly about adrenal incidentallomas. It's defined as any mass lesion more than 1 centimeter in size. They are common. As we get older, they become more common actually. Overall, it's in 2% of the general population, at up to 10% in elderly people. Most of incidentallomas are unilateral. However, 10 to 15% of them are bilateral. The question, of course, whenever we do a scan for whatever reason and discover an adrenal mass in a patient, the question that comes to our mind first, is it a benign tumor or it is a malignant tumor? And the second question, whether this adrenal is a functioning tumor, is it secreting hormone or it is a non-functioning one? Now, to answer the first question, whether it is a benign or malignant, of course, we rely on imaging, right? Basically, we start with CT scan. Now, in general, 2 to 5% of adrenal incidentallomas are malignant. So the vast majority are benign, and 1 to 2.5% are non-adrenal metastases in people usually who are known to have a primary malignancy and they have an adrenal mass. Now, factors to consider. First, size. 90% of adrenal cancers are detected when they are more than 4 centimeters in size. However, the reverse is not true. So the size by itself has low specificity, which means not all tumors that are more than 4 centimeters are cancer. Of course, the vast majority of tumors, even more than 4 centimeters, are non-cancerous. 75% are benign. But the bigger the tumor is, the higher the chance this can be malignant. Now, of course, imaging, we do CT scan for most of those tumors. The CT scan is very, very helpful. And actually, MRI does not add much to the CT scan in terms of sensitivity and in terms of specificity. So you do the CT scan. The first thing we look at, does it contain fat? So if the Hounsfield unit of the CT scan, this is a non-contrast CT scan, less than 10, it means this is an adenoma 100%, so it's not cancerous. Now, if you give contrast and there is more than 50% washout on the CT scan, also this is 100% benign adenoma. However, 30% of adenomas are lipid poor and they will not have that finding on the CT scan. In some controversial cases, or if the patient has primary malignancy, of course, the PET scan can be helpful in that case. Now, this is the typical appearance of a benign adenoma. So if you look at the screen here, this is how a benign adenoma looks like with low Hounsfield unit. It's usually homogeneous, it's smooth in contour, sharp demarcation, and it's on the CT scan low Hounsfield unit less than 10 typically. And on the MRI, if you do the MRI, it shows iso intensity with the liver on both T1 and T2. And if you give contrast, there's a chemical shift, which means the presence of fat in the tumor, or lipids, not fat actually, lipids to be more accurate. Now, some of the typical imaging of adrenal tumors, of course, we all know about the pheochromocytoma. Typically, pheochromocytoma does not have a low Hounsfield unit. It has a Hounsfield unit more than 20 on the unenhanced phase of the CT scan, and it's really vascular. So on the CT scan, you see increased vascularity. Sometimes, as you can see here, the tumor could be cystic or hemorrhagic. And it can vary in size. It can be a really big one. I'm doing one actually next week, 5 centimeter pheochromocytoma, and it can be bilateral, as you know, the rule of 10 in pheochromocytoma. This is the typical light bulb sign, which is the high signal intensity on T2 weighted MRI, where the pheochromocytoma looks like that. But this is, by the way, not specific nor sensitive for pheochromocytoma, so keep that in mind. Now, adrenal cortical carcinoma, as you can see here in the CT scan, it's irregular in shape. It's inhomogeneous or heterogeneous in density because typically we have central necrosis in it. It has calcifications. Usually they are big, more than 4 centimeters in size. Usually they are unilateral. And on CT scan, the unenhanced phase have high, more than 20 Hounsfield per unit. And when you give the contrast, it has heterogeneous enhancement. The same thing on the MRI. It is hypointense on T1 and intermediate to high on T2. And if you do PET scan, it's usually highly active on PET scan. And of course, in some cases, it invades directly the liver or it has evidence of metastasis. Adrenal metastasis actually share some features, almost the same features like primary adrenal cortical carcinoma. However, it has a tendency to be bilateral, as you can see it here, and usually the patient has a known primary. Now, this is a common tumor. Actually, makes 6% of all the incidentalomas. I think you can guess it just by the CT scan. It is grossly fat-containing tumor. It's myelolipoma. It's a benign tumor. We typically do not remove it unless it grows to a big size where it can bleed or it can cause mass effect. But this is one of the most common adrenal surgeries I do for big myelolipoma like this one. Now, the second question is functioning or non-functioning. Now, I'm not going to go through all the details of that. I'm a surgeon. Actually, you are the expert. The internist and the endocrinologist, of course, will lecture me on that. But I would like to discuss the 3 most common functioning adrenal incidentalomas. Now, most adrenal incidentalomas are not functioning. Only 10 to 15% are functional. And in terms of frequency, the subclinical Cushing syndrome is the number 1. Actually, that was new to me because I was reviewing the topic and I found out the subclinical Cushing syndrome is actually pretty common and in many cases underdiagnosed. Then it comes pheochromocytoma, and then the last one is aldosteronoma. Very briefly about subclinical Cushing syndrome, it makes 6% of adrenal incidentalomas. The other name for this syndrome is mild autonomous cortisol secretion. It's not like the Cushing syndrome. It has milder symptoms, and the symptoms are hypertension, dyslipidemia, diabetes, weight gain, osteoporosis, but it's not as severe as somebody with Cushing syndrome who has the immune suppressive and all the Cushing features, which is actually much rarer than this one. And the way we diagnose that is we see higher cortisol level of more than 1.8 microgram per deciliter when you do overnight 1 milligram dexamethasone suppression test. Now, pheochromocytoma, this is the only adrenal tumor that really scares me because you know how the presentation could be dramatic. And during this surgery, unless you do a very good alpha blockade with beta blockers as well, the surgery could be very risky surgery. It makes 3% of adrenal incidentalomas. Biochemical testing should be performed. Whenever we see a CT scan of adrenal tumor with more than 10 Hounsfield unit, we should always do testing for pheochromocytoma. However, if the Hounsfield unit is less than 10, we don't have to test for pheochromocytoma. We test for Cushing or subclinical Cushing or aldosteronomas, but not for pheochromocytoma. And just remember also one thing, small pheochromocytoma less than 1.5 centimeter in size might have normal biochemical testing. Now we know about the biochemical testing. I'm not going through the details. We do either blood metanephrines or urine metanephrines. And if they are elevated, typically it's a pheochromocytoma. Aldosteronoma is a rare one, 3%. If there is a classic presentation like hypertension, hypokalemia, high aldosterone, low renin, high aldosterone to renin ratio, this is a typical case of aldosteronoma. You don't need to further follow up. However, in many cases, you don't have that clear picture. And in many cases, you have to do other tests, mostly the aldosterone suppression test to verify it. All right. So this is a quick algorithm about how to manage incidental adrenal masses. If the Hounsfield unit is less than 10, you have to check whether it's functional or non-functional. If it's non-functional, you just observe. If it's functional, you remove. If the Hounsfield unit in the non-contrast CT scan more than 10 Hounsfield unit, then this we vary it on the size. If the size is more than 6 centimeter, you have to remove it, whether it's functional or not. If it's less than 6 centimeter and functional, you have to remove it. If it's less than 6 centimeter and non-functional, then you have to see the washout. If the washout is less than 60%, you remove it. If the washout is more than 60%, then you can monitor for size. And if there's a growth in size, you take it out. Anyway, let's talk now about surgery. I'm going to share with you the way I do my surgery. Those are my patients, my videos. I do robotic surgery. I don't do laparoscopic surgery anymore. I know many people in the audience are laparoscopic surgeons. I respect laparoscopy. To me, robotic surgery is the new face of laparoscopy. It's not new anymore. Actually, the first time I did it was 20 years ago in the US. But this is typically how the patient looks like. This is left adrenal tumor I'm going to remove. This is the patient on the operating room and the table. You can see the position. It's called lateral decubitus position. There is a beam bag here to hold him in place. Of course, padding. We have to make sure we don't injure the axilla. So there is, we have the SCDs here to prevent DVTs. This is our hospital here at CMC Dubai. Now, how I start after positioning, draping, is I introduce the Verus needle. I'm going to go into details because I think the vast majority of the audience are non-surgeons. So we make an incision in the left upper quadrant. We introduce a special needle called Verus needle, and we insufflate the abdomen with CO2. After that, we put the robotic trocars. You can see typically I put 4 robotic trocars and 1 assistant trocar. And then we bring the robot to the field. This is the patient. This is me. This is Dr. Walid Abed. And this is the robot. This is the Da Vinci Xi, which is the newest robotic system now in the market. Now, there are many others, but this is the first and one of the most advanced surgical robotic system. So after putting the trocar, we bring the robotic arms, and the robotic arms are docked, are attached to those trocars. And through those trocars, we put the robotic surgical instruments, which are the scissors and all the surgical instruments that we use during the surgery. So this is a robot right now being docked. That step takes literally, as you can see, like 5 minutes to do. And after this is the robot, how it looks like. This is the docked robot. The instruments are inside the abdomen. I do transperitoneal approach, and this is the surgical console where I sit and I control remotely the robotic instruments. Now, this is a left adrenalectomy, so I'm going to share with you through this scheme how the adrenal, some of the anatomy. So as you can see, the adrenal is sitting, as you know, is a retroperitoneal organ, so you have to reflect the bowel, the descending colon, in order to expose it. It's attached to the kidney, and there's the major vessel we need to control actually is this one, is the adrenal vein. The branches, the adrenal artery, those are usually small branches that we don't have to chase, but we can control with the help of the cautery. When we do the adrenal surgery, we have, of course, to be careful because the aorta is almost very close. The renal artery is very close. I'm going to show you that in real life. The pancreas is very close, and the pancreas is an endocrine organ, so can look sometimes like an adrenal, and the spleen, of course, is sitting on top of it. How does it look like? This is a 4 minutes video, and this will be the end of my presentation. So as you can see here, this is the left kidney. And here I already reflected the descending colon, but here I'm releasing some of the peritoneal attachment of the bowel. You can see the bowel medially there. And those are the peritoneal attachments. So of course the organ is retroperitoneal, so I have to reflect the bowel. Now this is the kidney here, that's the spleen. This is the renal artery, and this thing is the pancreas here. It's like the big thick fat is the pancreas. It's very important when we do the left adrenal surgery to expose the left renal vein and to expose, you can see the left renal vein, the big blue here is being visible because the left adrenal veins goes from it to the adrenal gland. Now we can see here, if you pay attention, this is the left adrenal gland starting to appear. It's different fat of yellow. It's kind of, that's how typical. This is an aldosteronoma, by the way, not a big one, like 2 centimeter aldosteronoma. Now, this is the left adrenal vein. And this is the first thing we need to control before even especially in pheochromocytoma, before we manipulate the adrenal, we have to control the adrenal vein. Now you can see it's not a small vein. I use the robotic clips and I clip the adrenal vein before I do further any dissection. One clip usually is enough. It's a vein. This is called hemolock clip, which is a locking clip. So once you put it, it's very difficult to open again. So this is the adrenal vein being cut now. Now, once I cut the adrenal vein, I can breathe normally because to me, this is the most challenging part of the surgery. And the rest, as I mentioned to you, the adrenal arteries are not like one big artery like the vein. They are small branches, and you can see I just cut one of them here. I use bipolar cautery and monopolar scissor, and the rest of the dissection becomes straightforward. Any small structure, vascular structure you can use. You don't have to use any clip anymore. It's all controlled with the help of bipolar cautery, as you can see here. Now, the robotic surgery will make this surgery much easier. I have done laparoscopy for many years, and I'm glad I don't do it anymore. Just I feel much more in control when I do robotic surgery. You feel totally immersed in the field, 3D vision, more accurate and meticulous move. But now you can see now, of course, when you do laparoscopic surgery, it's basically the same steps to some extent, but different instruments. So now this is the renal artery. You can see it here. And now this is the kidney. This is the last part of freeing the adrenal gland. So that surgery typically will take, for a small adrenal like this one, around 45 minutes. Of course, the bigger adrenals can take longer time. But in general, the surgery should take around 1 hour, 1 hour and a half, no more than that. Blood loss here in this case was literally zero. And this is the whole adrenal now removed. Of course, once we have the adrenal removed and securing the hemostasis, we insert the endocatch bag, which is a bag that opens inside the abdomen, and then we close the bag, and then we remove the whole specimen through the assistant trocar. And patients usually go home the next day. They don't have to stay more than that. And the recovery is pretty fast. So that's everything I have. Thank you very much. I hope it was an entertaining presentation. And I hope I was on time. I'll be more than happy to entertain your questions right now.
Thank you, Professor Rabia, for really well presented lecture. And of course, we saw the field, very clear field, and clear surgery, and we can say the minimum invasive surgery. Yeah.
Thank you, Dr.
Okay. So basically, my question is that the patients who are, if you have any local studies, what is the most common adrenal surgery you do now? Is it the non-functioning tumor or secreting adrenals?
Most of the tumors I'm doing here in Dubai so far are functioning. Surprisingly, I did, aldosteronomas, I did 3 of them, even though they are usually not that common, but for some reason they come to me. I did pheo before, and I'm doing a 5 centimeter pheo next week. And I did few myelolipomas, but they were like big ones, 9 centimeter and 15 centimeter. I haven't done in Dubai a cancer yet. Those are really rare, and thank God they are rare. It's controversial for adrenal cortical carcinoma to do it open or robotic or laparoscopic. Typically, if it's a big one, I prefer to do it open because of the possibility of local invasion, and with adrenal cortical carcinoma, you have to make sure you have negative margin 100%. But mostly, yes, mostly are functional, the one I do.
Thank you very much. We can just check if there are any question over here. So if no more questions, thank you again, Professor Rabia. Hopefully we get you on board next year with us as well. And we just try to shift for the next speaker.
All right. Thank you for the invitation.
Okay, thank you.
Dr. Rabia.
Thank you.
Dr. Reem, yeah. So it's my pleasure to introduce Dr. Reem Jafar. Dr. Reem Jafar Al-Argan, Dr. Reem, consultant endocrinologist, King Fahd Hospital of University, Hubar. Well, assistant professor in Imam Abdul Rahman bin Faisal University, Dammam. Obtained her BSc in King Faisal, and then obtained Saudi and Arab Board Internal Medicine 2011, followed by Saudi Fellowship in Diabetes Endocrinology under Saudi Commission Health of Specialties, followed by Endocrine Tumor Fellowship from Montreal, Canada, fellow of American College of Endocrinology, and has certification in endocrine ultrasound. Currently works as a consultant endocrinologist in King Fahd Hospital, University, and assistant professor in Imam Abdul Rahman bin Faisal University. Well, it's our pleasure to have Dr. Reem with us to talk about thyroid nodule. Dr. Reem.
السلام عليكم ورحمة الله.
عليكم السلام.
عليكم السلام دكتورة.
So, good afternoon, everyone. Thank you very much for the organizing committee for the invitation to be part of this conference. And thanks for the chairman of this meeting also for the nice introduction. So my talk will be about how to approach patients with thyroid nodules. So the outline of my presentation will start by a brief introduction about thyroid nodules, and then how to evaluate patients with thyroid nodules, starting with history and physical exam. What are the best laboratory testing in patients with thyroid nodules? And then we'll move to the evaluation of thyroid nodules with ultrasound and the available ultrasound stratification systems. And what are the new expected changes in the new American Thyroid Association guideline, which is coming this year? And then how to interpret the cytology after obtaining fine needle aspiration, and then the use of molecular testing in the diagnosis of thyroid nodules, how to do the active surveillance, and then the role of surgical treatment and minimally invasive techniques for thyroid nodules management. So starting with the introduction, so we know that thyroid nodules defined as discrete lesion within the thyroid gland that is ultrasonographically distinct from the surrounding thyroid parenchyma. Now, with the widespread use of sensitive imaging techniques, which include mainly visualization of the neck, we're having increased number of prevalence of thyroid nodules that demand attention of the physicians. So the prevalence in some studies could reach up to 60% of adults. In general population, they harbor one or more thyroid nodules. But the good news that the actual prevalence of cancer in thyroid nodule population is very low, and it ranges from in some studies up to 5%. With variation related to the selection criteria and the population under evaluation, for example, if they include papillary microcarcinomas or not. So most of the lesions with thyroid nodules, they are benign, they are asymptomatic, and they do not warrant treatment. And in case of the patient is diagnosed with cancer, most of them, they are small intrathyroidal and they're indolent neoplasms. In one large-scale study, up to 53% of the cases, they are small carcinomas and they are intrathyroidal. So we classify them basically as low-risk thyroid cancer. So in general, in other studies, they found that the prevalence of thyroid nodules could reach up to 36.9% in people who go for health checkups. And although they are common, as we already said, they are often asymptomatic, and not all of them, they are in critical condition. So most of them, they are asymptomatic benign lesions, and they do not affect the level of thyroid hormone secretion, and the risk of thyroid cancer in up to maximum could reach up to 13% of patients who have thyroid nodules. Now, women, they had significantly higher prevalence of thyroid nodules than men, and mainly we find it more in advanced age population in both males and females. If we look at this data, this is actually our data. We obtained more than 600 patients where they harbor around 730 nodules. We collected patients from 4 centers in Eastern Province of Saudi Arabia, and we found almost equivalent results to the international data, that most of the patients, they are above age of 40 years, whom they have thyroid nodules, and also majority of our cohort, they were females in 82% of the data that we collected. So how to evaluate patients with thyroid nodules? We basically start by history. So when you obtain history, we have to ask about symptoms related to either hypo or hyperthyroidism. And then we have to look for risk factors of malignancy, including history of childhood head and neck radiation, total body radiation, or exposure for radiation for any reason during either childhood or adolescence. In addition, we have to obtain family history of any syndromes, for example, related to thyroid cancer, like Carney syndrome, familial adenomatous polyposis, MEN type 2, which is basically risk for medullary thyroid cancer, and first-degree relatives. In addition, we have to ask about history of rapid nodule growth and history of voice hoarseness. Moving to physical exam, when we examine patients with thyroid nodules, we have to look for signs of either hypo or hyperthyroidism, and then we have to look for physical signs that could suggest possible malignancy, including vocal cord paralysis, cervical lymphadenopathy, or fixation of the nodule to surrounding tissue. Now, what is the appropriate laboratory evaluation for patients with clinically or incidentally discovered thyroid nodules? We usually start by measuring TSH, and that was actually recommended in the last ATA guidelines that was published in 2016. So serum TSH should be measured during initial evaluation of patient with thyroid nodule. If we find TSH to be suppressed, to be subnormal, then thyroid scan, preferably I123, should be performed. However, if TSH is normal or elevated, then thyroid scan is not recommended during initial imaging evaluation, but ultrasound will be best next step. So if we can look at this diagram, we could see that starting evaluation of thyroid nodule, we start by history, physical exam, and then we have to measure the TSH. If TSH is suppressed, then this means that this nodule, we need to make sure it's not functioning nodule, it's not toxic adenoma. So you have to complete the measurement of thyroid function tests. You measure the free T3 and T4, and then you could measure the antibodies like TRAB antibodies, and you do the thyroid scan to make sure if this nodule is hot or cold nodule. And in addition, if you have patients who have high TSH, again, you have to evaluate the patients for presence of hypothyroidism. So you will measure free T4 anti-TBO antibodies. And then you have to do the ultrasound to look for the risk stratification of the thyroid nodule. The same if the patient has normal TSH, then ultrasound will be the best next step in order to look at the risk stratification of this thyroid nodule to guide the decision for fine needle aspiration. How about the role of serum TG and calcitonin? So the latest ATA guidelines, they recommended that routine measurement of serum thyroglobulin for initial evaluation of thyroid nodule is not recommended. And serum TG levels can be elevated in most thyroid diseases, and there are insensitive and non-specific tests for thyroid cancer. So the panel could not recommend either for or against routine measurement of also serum calcitonin in patients with thyroid nodules. How about FDG BET? So because of the use now of FDG BET and evaluation of patients for other reasons, we could have sometimes uptake in the thyroid gland. So what are the recommendations regarding that? So if you find a focal FDG uptake within sonographically confirmed thyroid nodule, usually this thyroid nodule is considered at a high risk to harbor thyroid cancer. So FNA is recommended for those nodules if they are more than or equal 1 centimeter. However, if you have diffuse uptake in conjunction with sonographic and evidence of chronic lymphocytic thyroiditis, so this usually does not require further imaging or fine needle aspiration. How about the thyroid ultrasound? So if we look at different guidelines where they were published for management and evaluation of thyroid nodules, including the ATA guidelines, the European thyroid guidelines, and also the ACE guidelines, all of them, they recommend the use of thyroid ultrasound with surveillance of cervical lymph nodes in all patients whom either they are known to have thyroid nodules or they are suspected to have thyroid nodules. However, ultrasound evaluation is not recommended as a screening test for general population or patients with normal thyroid palpation and they have low clinical risk factors to have thyroid disease. Now, how to describe ultrasound findings? We have to focus in the ultrasound report to look for risk stratification of thyroid nodules in order to see the risk of malignancy, and then that will guide you to decide about the decision of FNA. So the first step, we have to describe the thyroid nodule in regards to the position, size, shape, margins, content, echogenic pattern, and vascular features of the nodules. If we have multiple nodules, then we have to detail the nodules bearing the ultrasound characteristics associated with malignancy. So we have to look for the most suspicious nodule rather than the largest or dominant nodule. And if you find suspicious regional neck lymph nodes, then we have to describe that lymph node in regards to the number, shape, size, margins, content, echogenic pattern, presence of hilum, and vascular features. Again, what are the elements that should be included in reporting nodular thyroid disease? So we start by reporting the thyroid loops itself, and then we report the nodule itself. And as we already mentioned, we have to look for the size, location, echogenicity, composition, and the presence of suspicious or non-suspicious signs. And then which discrete nodule should be described? Any nodule that is larger than 10 millimeter, and if it is between 5 to 10 millimeter, if it has suspicious signs. How many nodules should we describe? Either the largest one, and also those with suspicious signs if the number of nodules more than 3 in one loop. If we have pathological lymph nodes, again, we have to describe the location, the 3 diameters, and presence of suspicious features. What about the use of complementary ultrasound techniques? Are they helpful in evaluation of thyroid nodules? So we have the Doppler imaging. It may be indicated in order to differentiate between cases where vascularization is either diminished or absent. That will help you to differentiate if this is mostly cystic or solid nodule. Elastosonography, the contribution of this method to standard ultrasound imaging does not justify its routine use and inclusion in the risk stratification systems. There is another technique called contrast-enhanced ultrasound. There is actually inconsistency across the studies and publications about the use of this methodology in the assessment of thyroid nodules. Their use remain limited because the contrast agent is expensive, invasive, and not universally licensed for this purpose. So what are the features that could tell you that this nodule is going with benign rather than malignant, or the opposite? So the ultrasound features that indicate benign nodule actually either a spongiform appearance, means that it has microcystic spaces more than 50% of the nodule, or it is simple cyst with thin regular margins, or it is mostly cystic, more than 50% from the nodule containing colloids, or it has eggshell calcification around the periphery of the nodule. How about the features of malignancy? So usually the features of papillary thyroid cancer are solid hypoechoic nodule, which may contain hyperechogenic foci without causing posterior shadowing, and that's what we call microcalcifications, or solid hypoechoic nodule with intranodular vascularity and absence of peripheral halo. Or we have taller than wide nodules. Again, it's considered of the one high-risk features, or hypoechoic nodule with speculated or lobulated margins, or hypoechoic nodule with a broken calcified rim and tissue extension beyond the calcified margin. The follicular neoplasm, usually we can see it in the ultrasound as hypoechoic or mildly hypoechoic homogeneous nodule with intranodular vascularization and well-defined halo. There are some features which are considered indeterminate ultrasound features, which includes iso or hyperechoic nodule, mildly hypoechoic nodule with a smooth margin, peripheral vascularization, and intranodular macro calcification. We have many systems which could help to stratify ultrasound features, including the one published by American Thyroid Association, the ACE guidelines, Korean Thyroid Association, the ThyRights, which was published in 2017, and the last one is the European Thyroid Association, published in 2023. So this is the famous American Thyroid Association risk stratification system of thyroid nodules. So they basically stratify the thyroid nodules into high suspicion, intermediate, low, very low, and benign. And the high suspicion include any nodules that is hypoechoic plus other high-risk features. So in the presence, for example, of microcalcification, irregular margins, taller than wide, extrathyroid extension, or when we have soft tissue extrusion or presence of lymph nodes. The intermediate suspicion, when you have only hypoechoic nodule, however, in absence of other high-risk features. Low suspicion nodules, mainly iso and hyperechoic nodules with regular margins, or partially cystic nodule with eccentric solid area. Very low suspicion, which includes mainly spongiform nodules, and the benign when it is mainly cyst. And then we have the ThyRAD classification, which is widely used by radiologists. It basically contains many features of thyroid nodules, and then they ascertain certain points according to the features of the thyroid nodules in regards to composition, echogenicity, shape, margins, and echogenic foci. And based on the points that's collected based on the ultrasound features, they categorize them into certain levels from TRADS 1 to TRADS 5, and then the risk of malignancy usually highest at the level of TRAD 5 and lowest in TRAD 1. The other ultrasound stratification system is the one published by the ACE in 2016. So usually they have 3 levels, which is the low risk, intermediate, and the high risk. The low risk include most of the features included in ATA in the benign, very low suspicion, and low suspicion. So that includes the cystic nodule, or mostly cystic nodule in absence of other high-risk features, and the isoechoic spongiform nodules as well. The intermediate risk includes mainly the slightly hypoechoic nodule in comparison to the thyroid tissue, or isoechoic nodules with smooth or ill-defined margins. maybe these features could be present, like intranodular vascularization, elevated stiffness at elastography, and macro or continuous rim calcification and indeterminate hyperechoic spots. And that include actually the same category in ATA, which is classified as intermediate suspicion. And then we have the high-risk thyroid lesion when you have nodules who have at least one of the following features, which is marked hypoechogenicity, speculated margins, microcalcification, taller than wide, extrathyroidal growth, and pathological lymph node, and that equivalent to the high suspicion risk in the ATA guidelines. And then the last one is the one published in the European Thyroid Journal in 2023. They usually follow what is called European TIRADS, and they have from 1 to 5 categories. And then basically it's similar to the ATA, where 1 is mainly, there is no nodule, 2 is benign, mainly pure cyst and spongiform, low risk isohyperechoic nodules without other high risk features, intermediate, mainly mildly hypoechoic without other high risk features, and high risk when it has the other high risk features. We have also the Korean stratifications, where they look mainly first at the consistency of the nodules when it is solid, hypoechoic, or cystic. So if it is cystic, they classify it as benign. If it is solid, hypoechoic, they look at the ultrasound features. If it is present, this is high risk. If this is absent, then this is intermediate suspicion. If it is partially cystic or iso or hyperechoic, again, they look at the ultrasound features. If it's present, then this is intermediate. If not, then this is low suspicion. Now, how are these interrelated together, and what's the indication of FNA at different cutoffs of the different categories at different guidelines? So when we look at the benign category in different guidelines, most of them, they do not recommend to do FNA in such nodules because of the low risk of thyroid cancer. However, if we have the low risk, most of them, they recommend either maybe observation, and some they recommend to do FNA like at a cutoff of more than 2 centimeters, like in ATA guidelines, and in some guidelines like the Korean Association, they recommend to do the FNA at more than or equal 1.5 centimeters. For the mildly suspicious nodules, the American College of Radiology, the TIRADS, they recommend to do the FNA at a cutoff of 2.5 centimeters, and for ATA at a cutoff of 1.5 centimeters. For moderately suspicious nodules, most of the guidelines, they recommend at a cutoff of 1 to 1.5 centimeters. So for TIRADS at a cutoff of 1.5, and for ATA at a cutoff of 1 centimeter. For highly suspicious nodule, most of the guidelines, they recommend to do the FNA at a cutoff of more than or equal 1 centimeter. How about small thyroid nodules, which is less than 1 centimeter, but it has high risk features? So some guidelines like the ACE guidelines, they recommend to do FNA once the diameter is 5 to 10 millimeter when it is associated with suspicious ultrasonographic features. And that's specifically when you have subcapsular or paratracheal lesions, suspicious lymph nodes or extrathyroidal spread, positive personal or family history of thyroid cancer, or coexistent suspicious clinical findings. Again, also the European Thyroid Association, they recommend to do the FNA for such nodules if we have suspicious features like presence of suspicious lymph node or extrathyroidal extension. Now, how common are these stratification systems used by different specialties? We find that for example, the ATA guidelines is commonly used by endocrinologists and surgeons, and the TIRADS, whether the European or the Korean, for example, or the one published by the American College of Radiology, is commonly used by radiologists. Now, Are these comparables, those systems, or is there any difference among the performance of such system to predict thyroid cancer? There are some studies which looked at the sensitivity, specificity of those systems. They found that most of them, they have comparable effectiveness to predict the presence of thyroid cancer, with some minor differences among these systems. So again, in this study, they found that most of them, they have comparable effectiveness. The only difference that they found is that thyroid classification, it had the highest specificity, but it had lower sensitivity when it is compared to the American Thyroid Association. And that's because the thyroid, it uses higher cutoffs for different categories of risk stratification when you compare it with the ATA guidelines. Again, this was a study where they compared primarily the ATA versus thyroids, and they found that both of them, they had comparable effectiveness in prediction of thyroid cancer. The only difference is that the ATA was more sensitive in comparison to the thyroids, but the thyroids had higher specificity to predict thyroid cancer. So American College of Radiology, or the thyroids and ATA, they both have overall, they are similar in classification. However, ATA, it has lower FNA cutoffs. ATA could lead to more unnecessary biopsies, so it leads to lower specificity but higher sensitivity. The ATA, some of the nodules, around 7 to 10% of the nodules, still we cannot classify them based on the ATA risk stratification. And the ATA tends to be more sensitive, but the thyroid is more specific. The systems usually vary in the levels of thyroid cancer risk categorization used. Some of the guidelines, like the ATA thyroids, they recommend against FNA of highly suspicious nodule less than 1 centimeter. But as we already mentioned, some like the ACE, for example, and the European, they recommend to biopsy those nodules when they are 5 to 10 millimeter in the presence of high-risk features. And many physicians, they use more than one of the systems in practice. This is one of the results that we had in our study. Still, it's under process of submission to the journal, not yet published. But we found that when we looked at ultrasound features and how it is helpful to predict the risk of malignancy, we found that in multivariate analysis, the intermediate and high suspicion ultrasound features by ATA, it increased the odds of malignancy with significant p-values. In opposite, the benign categories of the thyroids, which is 1 to 3, it lowered the odds of malignancy, and the more suspicious thyroid features, which is the 4 and 5, it increased the odds of malignancy. So it is really helpful method to predict the risk of malignancy. Now, what are the expected changes that could come in the coming ATA guidelines in 2024? These slides were taken from the draft presented in last American Thyroid Association meeting. The problem with ATA guidelines that we still have some nodules, they cannot be classified based on the current ATA risk stratification system, and that ranges in different studies from 3 up to sometimes 13%, and they could harbor some malignancy risk. And that's mainly in nodules where we have the echogenicity or the composition is not clear, and nodules with mixed cystic and solid nodules, however, with the presence of suspicious features, or hyper or isoechoic nodules, again with the presence of suspicious features. So the aim of the next guidelines is to limit the number of the unclassifiable nodules to a very low percentage from the current one, and to have at least 90% of the nodules to be classified by the ATA risk stratification. So this is the expected change that could come in the next guidelines. They will depend mainly first to stratify the nodules is to look first at the consistency. So if we have a nodule which is more than 90% solid, they will define it as solid nodule. more than 10% cystic, it will be defined as cystic nodule, or sometimes the third one if we cannot assess the consistency. If it's solid nodule, then we look at the echogenicity. So if it is markedly hypoechoic, or it is hypoechoic but not markedly hypoechoic, or if it is iso or hyperechoic nodule. And then they will classify the suspicion based on the echogenicity. So if it is markedly hypoechoic, plus presence of one suspicious features, then this will be classified as high suspicion. However, if it is only mildly hypoechoic, but with at least 2 suspicious features, then this will be high suspicion. If the patient has markedly hypoechoic, however, in the lack of other suspicious features, or hypoechoic with 1 suspicious features, or iso and hyperechoic with more than 1 suspicious features, this will be classified as intermediate suspicion. If you have only hypoechoic or iso or hyperechoic, however, without the presence of suspicious features, so this will be low suspicion. And this is a change from the last guidelines, because the last guidelines, any hypoechoic nodules was classified as intermediate suspicion, but here they will move it into low suspicion in absence of other high-risk features. If you have cystic nodules, then you have to look, is it partially cystic, is it spongiform, or it is entirely cystic? If it is entirely cystic, then this is benign. However, if it is partially cystic, we have to look at the other features also in order to look at the level of suspicion of thyroid nodule. So it will be defined as high suspicion if it has either acute angled protrusion or intrasolid microcalcification or macrocalcification. Intermediate suspicion if it's only, so it has solid component with acute angled protrusion without the presence of microcalcification. And if it will be low suspicion if it has only solid component with lobulated interface with cystic or concentric. And very low suspicion if it's only partially cystic in absence of all of the other features that we already described before. And also for the microcystic or spongiform nodule, it could be either low or very low suspicion. So low suspicion if it has other features like macrocalcification, speculated margins, or irregular halo. And very low suspicion if it's only spongiform without the other high-risk features. And if we cannot assess the consistency, we have to look at the other features. So does the nodule has, for example, peripheral calcifications or central dense calcification? So this will be classified as high suspicion. If it has irregular peripheral calcifications without protrusion of the soft tissue, this will be intermediate. And if it is only thin regular peripheral calcification without protrusion of soft tissue, this will be classified as low suspicion. And what are the indications of FNA at these sonographic patterns, different sonographic patterns? So at the high suspicion, now they put a range of diameter for the nodule rather than only one cutoff. So the high suspicion is indicated for FNA when the largest diameter is between 1 to 1.5 centimeter. The intermediate when the diameter is between 1 to 2 centimeter. The low suspicion when the diameter is between 1.5 to 2.5, and the very low suspicion, you could have the option of either observation versus considering FNA when the size is more than or equal to 2.5 cm. And the benign, there is no indication for fine needle aspiration. And what will guide you to take either the lower cutoff or the higher cutoff? In the presence of young patient, then you take the lower cutoff, older patient, the larger cutoff. In the presence of personal risk factors for thyroid cancer, you take the lower cutoff. In the presence of comorbidities, you take the higher cutoff. Presence of high-risk features in the ultrasound, then disfavor the smaller size cutoff. In the presence of uptake in FDG-BET, you take the lower cutoff. And in case of symptoms attributable to the nodule, you take the lower cutoff. And when the location of the nodule is either isthmus or posterior, again, you take the lower cutoff because of high risk of a tracheal invasion. Now, we already took the FNA, how we interpret the cytology. Most of the guidelines, they recommend to use the Bethesda classification system to report cytology reports of thyroid nodules. Now, the Bethesda classification has been modified in the last year, in 2023. So the last report that we have, we still have the 6 classes of Bethesda classification. The Bethesda one, which is now called non-diagnostic, when you have only cystic fluid without cells in the specimen. And then we have Bethesda 2, which is mainly the benign nodule, and that could be either consistent with follicular nodular disease, chronic lymphocytic thyroiditis, or granulomatous thyroiditis. And then we have the Bethesda 3, which is the ATB of undetermined significance, but here they recommend to specify where is the atypia. Is it cytoplasmic, for example, or a nuclear atypia? And then we have the follicular neoplasm. Again, they recommend to specify if it's oncocytic, like Hurther cell type or not. And then we have the suspicious for malignancy. And then the last one is the malignant cytology. The risk of malignancy, of course, differs among the different categories of Bethesda classes. So, for example, the non-diagnostic, it has risk of malignancy of 13%, the benign 4%, 22%, 30%, and it is very high in the 5 and 6 classes. So 74 in 5 and 97% in Bethesda 6. And then the management will depend on the results of the cytology report. So if it is non-diagnostic, we have to repeat the FNA under ultrasound guidance. If it is benign, we could continue to follow those patients with either clinical and ultrasound follow-up. If it is ATB of undetermined significance, you have the 3 options of the repeating FNA, molecular testing, and diagnostic surgery or surveillance. If it is follicular neoplasm, we have the molecular testing and diagnostic lobectomy. Suspicious for malignancy, we could do molecular testing, but also surgery is very important in this category, either lobectomy or near total thyroidectomy. And of course, malignant, we have to send patients for surgery for either lobectomy or near total thyroidectomy. So if we have a non-diagnostic cytology, FNA should be repeated with ultrasound guidance and, if available, on-site cytology evaluation. But how about if you repeat the FNA and it is still non-diagnostic nodule, then you have to go back and look at the ultrasound features. If the nodule is high suspicion by ultrasound, then you either closely observe this nodule or you send the patient for surgery. So surgery should be considered for histopathological diagnosis if the cytology remains non-diagnostic and it has high suspicion sonographic pattern, or you demonstrated already growth of the nodule and follow-up at least 20% in 2 dimensions during the ultrasound surveillance, or if the patient has clinical risk factors for malignancy. How about ATB of undetermined significance? We already mentioned that we have different options to manage this Bethesda class, either active surveillance, repeat FNA, molecular testing, and surgery. If we choose molecular testing, then patients should be counseled regarding potential benefits and limitations of testing and about the possible uncertainties in the therapeutic and long-term clinical implications of results. If you repeat the FNA cytology or molecular testing or both, and still they're not conclusive, then you have the option of either surveillance or you do the diagnostic surgical excision in such Bethesda class. And that will depend on clinical risk factors, sonographic patterns, and patient preference. So the expected coming recommendation in regard to this Bethesda class, that ultrasound surveillance will be better for patients who have very low suspicious ultrasound features, and the repeat FNA and molecular testing will still be an option. However, patients who have very high suspicion ultrasound pattern, or there is a growth of the nodule or pressure symptoms or strong patient preference, surgery will be recommended. How about follicular neoplasm or suspicious for follicular neoplasm, which is the Bethesda 4? Diagnostic excision was the long-established standard of care for management of this class. However, after consideration of clinical and sonographic features, molecular testing may be used in such Bethesda class, and that in of course, discussion with the patient. So we have to have the informed patient preference and feasibility should be considered in the decision-making. In case molecular testing is not performed or inconclusive, surgery will be considered for definitive diagnosis of this thyroid nodule. How about Bethesda 5, which is suspicious for malignancy? Of course, management should be similar to that of malignant cytology, and that will depend on clinical risk factors, sonographic features, and patient preference. But what's the role of molecular testing in this category? After consideration of clinical and sonographic features, mutational testing for different gene mutation may be considered in this class, and that will help in the decision or making of the extent of surgery in such category. So we have different molecular testing that's available, which include the Afirma, the Thyroseq V3, and the Thygenix or Thyramir. The Afirma, actually, it includes microRNA expression. It has more than 1,000 genes. The Thyroseq has targeted DNA and RNA next generation sequencing. The Thygenix has targeted next generation sequencing and microRNA expression. What's the differences among these molecular tests? The Afirma has a high negative predictive value, so it is mainly a rule-out test. It will help you to rule out malignancy. The Thyroseq has the highest negative predictive value in marketing study, and it has the most comprehensive mutation, so it is very helpful test also to rule out malignancy in suspicious thyroid nodules or indeterminate thyroid nodules. The Thygenix has comparable negative predictive value, but it has very high positive predictive value. So it is considered mostly one of the rule-in tests. It will help you to rule in malignancy in indeterminate thyroid nodules. And it is best to predict the risk of malignancy for RAS positive nodules. So how you approach those patients when you do for them molecular testing. So when you do the Afirma, it will be reported either benign or suspicious. When it's benign, risk of malignancy or NFTB is only 4%, so you observe this nodule. If it is suspicious, then the risk of malignancy 50%, so you have to do lobectomy. When you do Thygenix or Thyramir, it will be reported either negative, moderate, or positive. When it is negative, then you observe. When it is moderate, you either observe or you do lobectomy. When it is positive, then you have to do lobectomy. The Thyroseq will give you the exact mutation. So it is either negative, then you observe. If it is positive, RAS-like mutation, this is considered mostly low-risk cancer or NFTB, so we do lobectomy. However, if the patient has positive HER2 cell type of copy number alteration, then you do either lobectomy or total thyroidectomy because this is considered intermediate risk cancer. If it is BRAF positive, again, this is intermediate risk, so you either do lobectomy or total. However, in the presence of high-risk mutation like TERT mutation, for example, then this is high-risk cancer, so it's better to do total thyroidectomy plus minus lymph node dissection. So if we have indeterminate nodule and you will send the patient for surgery, what will be the extent of surgery? So it will be the recommended initial surgery is actually lobectomy, but this approach may be modified based on clinical or sonographic characteristics, patient preference, and the results of molecular testing. So because of increased risk of malignancy, in some patients, we could do total thyroidectomy in indeterminate thyroid nodules, and that's mainly when the cytology is suspicious. The patient is known to have mutations for carcinoma. Sonographically, the nodule was suspicious. The nodule is large, more than 4 centimeters, or the patient have risk factors for malignancy, like familial thyroid cancer, history of radiation exposure. What about other factors which could also help you to decide about doing total thyroidectomy in indeterminate thyroid nodule? In patients who have bilateral nodular disease, patients have significant medical comorbidities, or patients, they prefer to do bilateral thyroidectomy to avoid the possibility of requiring another surgery, they may undergo total or near total thyroidectomy. How about if you have malignant cytology? Of course, the recommendation is to do surgery. It will be either lobectomy or total thyroidectomy, depending on different risk factors. In benign cytology, we have to do further active surveillance without the need to do further diagnostic studies or treatment. When you will follow those patients, in the last guidelines, in the one published 2016 by ATA, they put the frequency of active surveillance depending on the suspicion of the thyroid nodule when they have benign cytology. Suppose you already did FNA, the patient had benign cytology, when you will follow up those patients. When it was high suspicion by ultrasound, then you have to repeat ultrasound plus the ultrasound guided FNA within 12 months. When it is low to intermediate suspicion, then you repeat the ultrasound at 12 to 24 months. And then when you demonstrate the growth of the nodule defined as a 20% increase in at least 2 dimensions, or an increase of at least 2 millimeters, or more than 50% change in volume, then they recommended to repeat the FNA. In patients who had nodules with very low suspicion ultrasound, then the utility of surveillance here is limited. However, if you will repeat, the ultrasound should be done at more than 24 months. The expected change in the new guidelines that the frequency of follow-up will be more relaxed. So in patients who have—
Professor Reem, we have 3 questions also. So 2 minutes if we can.
No problem.
Okay, thank you.
So the expected change in the new one, so if you have a very low risk of malignancy, then they do not recommend to do ultrasound follow-up. However, if it is low risk of malignancy, then at 3 to 5 years, they recommend to do the ultrasound follow-up. And for the intermediate risk, 18 months to 3 years, and for the high risk within 12 months, but they recommend to repeat the FNA for all nodules. How about surgical treatment when you have benign thyroid nodules? So it was recommended in different guidelines that some benign nodules, you could send them for surgery if you demonstrate growing nodules and they are large, like more than 4 centimeters, and they are causing pressure or structural symptoms, or sometimes based on the upon clinical concern. And that was actually published in different guidelines, and they agreed about this indication. How about the use of minimally invasive techniques? Now we have different minimally invasive techniques that are available in management of thyroid nodules, like the use of ethanol ablation and also the thermal ablation as well. So most of the guidelines, they recommend to use the ethanol ablation mainly for cystic nodules and the thermal ablation for the solid nodules when they demonstrate growth, or the patient has pressure symptoms also, or sometimes for cosmetic concerns. And that was agreeable among different guidelines, including the European guidelines, the ACE, and also the ATA guidelines. So to conclude, we, as a start of thyroid nodule evaluation, number 1, we have to take history physical exam. You have to measure TSH. If TSH is low, then you do thyroid scan. If it's normal or high, then you do thyroid ultrasound. And then you have to look at the different features of the ultrasound. If the nodule is indicated for FNA, then you have to look at the different Bethesda classification. If it is Bethesda 3, you have the different options of managing Bethesda 3, Bethesda 4, mainly molecular testing or surgery, Bethesda 5, either surgery, of course, and molecular testing could help you to decide about the extent of surgery. 6, of course, it will be surgery, and the benign mainly for active surveillance. So in summary, thyroid nodules, it's common clinical condition. Basic history physical exam is the first step in evaluation. Serum TSH is the best laboratory test in evaluation of thyroid nodules. Ultrasound remains an important tool in stratification of risk of malignancy. We have many ultrasound stratification systems. They all have similar effectiveness with some differences. All cytology reports should follow Bethesda classification. Management should be decided accordingly. New updates are expected in the risk stratification of ATA in this year, 2024, and there will be movement to less aggressive in the either workup or also the active surveillance. Surgery and minimally invasive techniques to manage benign thyroid nodules have its own indications. Thank you very much.
Thank you very much for a nice presentation, Professor Reem. And Well, because of the time shortage, if you can answer the questions directly by typing, and we will proceed for the next speaker. So it's already in the QI. Yeah, well, you have 3 questions. I can mention first one only. During follow-up of long-standing benign nodule, any case develop malignancy later on? Well, maybe looking for the GLP-1, Ozempic. This is the question. Yeah.
So,
And yeah.
so it's not, so Ozempic or GLP-1 agonists are contraindicated mainly in patients who have either established history of medullary thyroid cancer or family history of medullary thyroid cancer. But for papillary thyroid cancer, still we don't have strong evidence that says that it is either contraindicated or it has link with papillary thyroid cancer. So you don't need to screen those patients for thyroid nodules when you want to start GLP-1 agonist, rather than taking a basic history of medullary thyroid cancer. This is the most important thing whenever you want to start patients on GLP-1 agonist.
Okay, there is another question. Well, in your series, Dr. Muhammad Al-Arab, any case reported that cause of thyroid nodule is genetic, like Pendred syndrome? And if present, what is the ultrasound picture?
So in our study, actually we were looking mainly at the risk of thyroid cancer in large thyroid nodules. So we did not have any of our patient had like genetic diseases, for example, or not. So we did not look actually into the background genetics, because we were looking for something specific, which is the risk of thyroid cancer in large thyroid nodules, and if it is different from smaller thyroid nodules. So that was not our aim in this study.
Thank you very much. Now we will shift for the next speaker, Dr. Iman, if you can present Dr. Naufal. Thank you, Dr. Iman.
Yes, hello everybody. It gives me pleasure to introduce our next speaker. Actually, there'll be 2 of them, but each one of the doctors will present for 15 minutes. So I'll start just now for this first 15 minutes and present Dr. Michel Naufal, who is a president of the Lebanese Psychological Association. Dr. Michel Naufal is a mental health professional. He is a medical doctor and a licensed clinical psychologist in Lebanon with a focus on cognitive behavioral therapy. He received his undergraduate education in pre-medical studies at the American University of Beirut in 1998, after which he has earned his medical degree from St. George University School of Medicine with clinical rotations at the Brooklyn Hospital Center in New York, Cornell University affiliate in 2003. Dr. Michel, the floor is yours. You can share your slides.
Thank you very much, Dr. Iman, for this nice introduction. I will share my slides now. Okay. Okay. Yes. First of all, good afternoon from Beirut, Lebanon. I would like to thank the board and the committees that organized this IMDO conference. I'm very happy to be taking part of this with my colleague, Dr. Jeremy Alford, who will be giving the second part of this talk. I would also like to thank my friend, Dr. Hisham Khalfan, for bringing this conference to my attention and hence being able to take part in this. It's really nice that the topic of eating disorders has been included in a conference of internal medicine and endocrinology, because we know that there is a high comorbidity between eating disorders and a lot of the diseases that are seen in internal medicine. And particularly so in endocrinology. And unfortunately, not a lot of medical conferences include psychological disorders, which are, in this case, eating disorders that are both behavioral as well as medical conditions. The first thing before, like we start the second part, which is about the bariatric surgery considerations and what to look for, I wanted to give my part on introduction and a refresher of the eating disorders. So eating disorders at a glance, as you may know them, and that would be a refresher for some, are the following: anorexia nervosa, bulimia nervosa, binge eating disorder, pica, rumination disorder, avoidant restrictive food intake disorder, RFID, and there are other non-otherwise specified eating disorders as well. I will briefly talk about those and kind of define them. And I will start with what we call the binge eating behavior. There is a concept in eating disorder that is important to keep in mind, that there are certain people who actually present with what we call disordered eating, and it's not necessarily diagnosable as an eating disorder. It's obviously a risk factor when a person's eating hygiene and eating behavior are disordered, and that could be a predictor of an eating disorder potentially developing. So binge eating behavior, not as a disorder, but as a behavior, is basically when a person eats a very large amount of food in a very short period of time, and they have like this lack of control over how much they're eating in this short period of time. They eat even if they're not hungry. They eat until they're uncomfortably full, and sometimes they actually feel pain in the stomach and the intestinal area because of the amount of food that they ate. They tend to feel guilty and disgusted afterwards, and they tend to do this when they are alone. Now, binge eating disorder is when the binge eating episodes happen recurrently, and there is a marked distress regarding the binge eating that they do. And basically, it happens at least once a week for 3 months or more, and sometimes, actually, most of the times, much more than that. In binge eating disorder, we don't see a compensatory behavior, which we see in anorexia and in bulimia. Bulimia nervosa is a recurrent episodes of binge eating followed by inappropriate compensatory behavior, which is the difference with binge eating disorder. In bulimia, after the binge eating episode, individuals or patients tend to compensate for this binge that they've done immediately before. And this can include vomiting, misuse of laxatives, misuse of diuretics, using some medications to lose weight, fasting, restricting food after they've taken, after they've done the binge eating, and they may actually engage in excessive strenuous exercise with the intention to compensate for the binge because they feel guilty, they feel anxious, they feel scared of the calories that they have ingested. Now, let's not forget that in anorexia, which I will mention now, we also have sometimes some binge eat type of pattern. But anorexia, the way we know it, is persistent restriction of any type of food that can increase body weight. There is a fear of gaining weight. And because they are in continuous type of starvation-like mode, they have the inability to have a good and coherent perception and valid perception of the way they look. So they have a distortion of their body shape, and they may actually consider that they are above weight with respect to what they think as a reference. However, of course, we all know that the BMI is an important specifier in anorexia nervosa. Nevertheless, BMI should not be taken into consideration on its own. It is a little bit overrated sometimes. Yes, it gives us some idea of what the severity of the weight is with respect to height. However, it is not on its own enough to diagnose anorexia nervosa. Some individuals can actually have normal body weight and actually would be diagnosed with anorexia nervosa. Most individuals with bulimia nervosa tend to have normal body weight, but some anorexia patients can also have some normal weight for their height, especially of the type which is the purging type. So if you look at the bottom of the slide, there are two subtypes. One of them is the restricting type, which is the one that I just defined, where individuals try not to eat in order not to gain weight, and also because they fear the lack of control about actually putting on weight, so they restrict food. The second type of anorexia nervosa is often confused with bulimia, and in this case, the purging type, very similar to bulimia, individuals may actually look of normal weight or not, but they tend to engage in purging behavior as well. For pica is when individuals ingest non-nutritive substances, and obviously this causes, like some certain deficiencies. Nutritive substances are not much ingested. Usually it's things such as paper, such as pieces of wood, anything really that may not be nutritive or beneficial to the person's health. So we obviously have in kids failure to thrive. There is low functioning, poor cognitive functions, and this can affect a person's social life as well. Rumination disorders, when individuals eat food, but at the same time they either kind of rechew the food that they have regurgitated after they've swallowed it and then re-swallow it again or spit it out. So this is also one of those disorders that is not much mentioned when we talk about eating disorders. Avoidant restrictive food intake disorder, we see this a lot in kids. It's basically when individuals are very selective in the meals they take. And when they are selective, I mean, this is very limited to very specific types of foods. And unfortunately, it's too limited to a point where individuals fail to meet appropriate nutritional and energy needs associated with either a failure to thrive, significant nutritional deficiencies, and interference with psychosocial functioning, negative interference with psychosocial functioning. So ARFID is also sometimes underdiagnosed, and it's important to screen for that when we see individuals with disordered eating. Something which is interesting to mention today in our talk is what we call the 9 truths of eating disorders, things that many individuals know, but some may not know. First of all, many of people with eating disorders may look healthy. So if an individual, looks of normal body weight, that does not mean that they do not suffer from an eating disorder. So many people with eating disorders may look healthy, yet may have a severe eating disorder. That's number one. Number two, families are not to blame. It's very important for families to be an ally to the patient. So families can be the patients and the providers' best allies in the treatment. So families are a very important component. And as a matter of fact, in the treatment of eating disorders, it's basically a comprehensive treatment, which includes a psychiatrist, a clinical psychologist, and psychotherapist. Family needs to be on board. We usually also need medical doctors, cardiologists, endocrinologists, family doctors, and other specialists as well. Point number 3, an eating disorders diagnosis is a health crisis that may disrupt the person and the family's functioning. So it can cause a lot of discord in the family. Individuals may refuse to go eat at their cousins. They may refuse to sit with their family over dinner. And it can cause a lot of friction between family members, particularly between the individual struggling with the eating disorder and his, her, or their family members. Eating disorders are not a choice. An individual does not decide to stop eating and restrict food and become anorexic because they want to. They are actually serious illnesses. They are biological, medical / psychological, behavioral, psychiatric illnesses. They are not a decision. A person does not decide to actually purge. They can engage in a purge as a behavior, but when it becomes a diagnosable disorder, then we are at the point where the individual's decision on behavior is no longer a choice. Point number 5, eating disorders affect people of all genders, all ages, all races and ethnicities, all body shapes and weights, all sexual orientations, and socioeconomic statuses. And here I would like to mention that eating disorders also affect men. We tend to think of eating disorders affecting women. They do start most commonly in women and adolescents, but they also affect men. And this is a bit underdiagnosed. Today, with social media and with certain jobs that they require certain weight limits, for instance, let's say as cabin crew on planes, models, so on and so forth, this requires some individuals to undergo severe dieting. And we know that dieting is a high risk factor for the development of eating disorders in vulnerable populations and populations that actually have a predisposition for eating disorder. And you probably know that in some countries, this has been banned, and individuals, like applying to certain jobs are no longer forced to follow a specific diet in order to get the job. And this is now illegal in a lot of countries, fortunately. So men do get affected with eating disorders, and social media has played a big role in increasing the incidence of eating disorders worldwide. Point number 6, eating disorders carry an increased risk for both suicide and medical complications, as well as death from medical complications. So it is among the top 2 mental health disorders for when we talk about death. So the risk of death in the mental health, if we take all the mental health disorders, among the top 2, we can include eating disorders. Eating disorders are fatal disorders to a certain extent, and we see a lot of individuals either attempting and committing suicide or die from some medical complications because of their eating disorder, whether it's a heart attack or if it's a stroke or other type of medical issue. Point number 7, genes and environment play a role, and they play an important role in the development of eating disorders. So it's not just genes, but also the environment, like I mentioned, the social pressure, especially in the Middle East. This is something that is taken kind of like a little bit too seriously about how we look, particularly on women, but also on men. And social media did and still does play a role in the surfacing of eating disorders in individuals who have genetic predisposition. In mental health, we usually look at disorders from what we call the biopsychosocial model. So biological, whether it's genetic and or hormonal or chemical. The psychological component, which is basically the personality of the individual, the way they are raised, they are brought up, their psychological structure and the way they think, the cognitive model, the cognitive style of the individual, and of course the environmental triggers, so the biopsychosocial model. Point number 8, genes alone do not predict who will develop eating disorders. So a lot of individuals with predisposition at the genetic level may not end up having an eating disorder being diagnosed. So we need to screen that and not underestimate individuals who do struggle with eating disorders and are not diagnosed. Full recovery from eating disorder is possible, and the key is early detection. And for early detection, screening needs to be included. So if we don't screen for disordered eating and for eating disorders, there is a high risk of us missing eating disorders, and hence the treatment will be delayed. I would like to mention the association in the Middle East called the Middle East Eating Disorders Association, MIDA for short, which is an NGO, nonprofit organization founded in 2009. And it is a Middle East partner chapter of the Academy of Eating Disorders. It's a growing organization, and at this point, we're still looking for funding, and it includes health professionals, volunteers specialized in eating disorders, not only psychologists, but also medical doctors from different fields, as well as nutritionists. So the mission is to raise awareness about eating disorders and to strive towards spreading prevention in the region, to offer support and guidance to sufferers and the families, to recommend and provide eating disorder training to healthcare professionals. And my colleague, Dr. Jeremy Alford, is the current president and the founder of MIDA in the Middle East. And if you basically look at the bottom left of the slide, you will see the website of MIDA, which is www.meeda.me, standing for Middle East. And this is basically the slide, which is the first slide that you'd see, or basically the main homepage of the Middle East Eating Disorder Association on the website. I thank you for your attention to my part of the talk. Now I will give the floor to my colleague, Dr. Jeremy Alford, to do the second part on the bariatric surgery considerations and what to look for. Thank you.
Thank you, Dr. Michel, for such a nice short presentation. We'll move on now to Dr. Jeremy Alford, who is a clinical psychologist with over 20 years of mental health experience, working in multicultural settings in the UK, Middle East, and Southeast Asia. Dr. Jeremy runs his own customized mental health wellness retreat program, as well as consults in private practice. Dr. Jeremy has graduated from the University College Kingston in the UK. He adopts a person-centered multimodal approach consisting of cognitive behavioral therapy, mindfulness, clinical hypnotherapy, and biofeedback as well. He has a core specialization in the treatment of eating disorders and obesity. And as a senior lecturer, Dr. Jeremy trains and supervises healthcare professionals with the latest thinking from a range of evidence-based psychological approach, including health psychology and other approaches, offering those with eating distress or even weight management hope recovery and change. Management, hope, recovery, and change. He is stigma aware, gender aware, and sensitive in the needs of every person. Dr. Jeremy, the floor is yours. Dr. Jeremy, are you there? Dr. Michelle?
Yes, I'm here, but it seems like Dr. Jeremy is no longer in the panelist list, so he either got disconnected or he was thrown back into the attendees list. So
no, can you check with him, please?
Yes, of course I can. I will reach out to him. Just a moment, please.
Yeah, okay.
We can take some questions for Dr. Iman.
Yes.
Until Dr. Jeremy join.
Okay.
So any questions for?
I don't have any questions in the questions book.
Yeah. Well, I have a question for Dr. Nofal. It's well, we have one of the medication we are use for obesity, which is the bupropion with the naltrexone combination. And when we wish to start that, many of the patients, they use antidepressants, like again, different antidepressants. And you know that and many of the antidepressants increase the weight. So what's your experience with bupropion as antidepressant for the weight?
Yes.
Behavior.
I would like to mention, first of all, that I am a medical doctor. I do prescribe medications. I'm not a psychiatrist, though. However, what I would like to say is that we do use antidepressants with individuals who struggle with depression and other disorders as well, such as anxiety, OCD, panic disorder, among other disorders as well. So we use them in different indications. For bupropion, it's one of those antidepressants where the risk of weight gain is less than, let's say, SSRIs or SNRIs. However, it's very important to take into consideration the fact that bupropion, first of all, may not be available in all countries in the Middle East, but at the same time, it also doesn't cover all of the anxiety disorders as well. And we see that there is a high comorbidity between anxiety disorders or anxiety spectrum, the way I call it, between social anxiety, generalized anxiety, as well as, in this case, depression. So sometimes when anxiety is prominent, we may move away from bupropion because bupropion may not be the optimal medication to cover both the anxiety part of the presentation as well as the depression part. Now, when we talk about the combination of naltrexone and bupropion, some individuals are prescribed this medication for the sake of weight loss. I personally don't prescribe it for that matter. If it is prescribed, it's usually prescribed when individuals, struggle from, let's say, a concomitant depression and some sort of dependence on alcohol and or cannabis. Yes, Dr. Alfred is here now, so I guess we can go ahead and move to him. Yes, okay.
He can share his slides.
Yes.
Jeremy, you already
Jeremy, you can go ahead.
Yeah, please share your slides.
Maybe you need to give him access to share his slide. Oh, here he is. Okay.
Hello, everyone.
Hi, doctor. Hello.
Okay, hello, doctor. Hello, everybody. Apologies for the delay. I just had an unfortunate thing that just happened like just a few minutes ago. My computer completely crashed. So I am lucky enough to be able to borrow somebody else's laptop and to have all my presentation already sent on my email. So I'm setting everything up very quickly right now. I don't know if this has ever happened to you before.
Things happen, doctor. No worries. That's okay.
Okay, so let me see. So I have to share my my presentation. 1 second.
Yes, just click on the share screen button in the middle, the green one.
All right. Yes. Okay. Share screen.
Yes, and select your presentation, please. Dr. Jeremy, do you want to share your presentation via WhatsApp to Dr. Michel? He'll pass it on to us, then we can share it from here for you.
I have it here. Just a second. I'm just open. It's just I'm trying to manipulate the computer.
Okay. Okay. Take your time.
Okay. Share now.
Yes, we can see it. You can put it in slideshow, please.
Yes, I will. Let me see if in. Okay, so now I put it in. I want to see if it's going to open correctly. Okay, thank you for all for your patience. We're ready to go.
Yeah, you can go ahead, doctor. Thank you.
Okay, so Dr. Naufal, I presume has already presented MIDA to you all. So I will just like to say very briefly what MIDA consists of. So it's an NGO whose mission has been to raise awareness and provide support and recommendations to people who are struggling with eating disorders. And as you might know, eating disorders is the deadliest of all mental health disorders, and it is something that is not given much attention to. And this is why this association has been set up in 2009. And we are a growing community of eating disorder specialists in the region who specialize in this field. MIDA is also part of the Academy of Eating Disorders, which is a representing body around the world for like-minded associations working towards a similar cause to raise awareness and provide support and guidance. We also do support. I provide also trainings, accredited trainings through the National Center of Eating Disorders in the UK. And also I provide specific trainings as a senior lecturer for the National Center for Eating Disorders in the UK on latest psychological approaches to work with people with obesity. So the topic of today will be on, it's a very specific topic. Of course, it's those who've chosen to undergo bariatric surgery and aspects of this. And this is a very complex field. And we only have just about 15 minutes to give you a very brief overview of this, but I'll be talking about it from a psychological point of view and a very important angle that really must be considered or at least to be included within the treatment process of patients who decide to undergo surgery. So if you have any questions along the way, please don't hesitate. I like to keep this interactive. You might actually add your questions perhaps in the chat, which I don't see on the screen here, but I'll be waiting. So don't hesitate to interrupt me in this process. So I presume Dr. Naufal has already talked very briefly about the various types of eating disorders, the most common ones, as well as the least. So we know that among the general population, the prevalence of eating disorders is relatively low. However, among people in larger bodies that seek help, rates of eating disorders are much higher. So, yes? Hello?
No, I think maybe by mistake, Dr.
By mistake. Okay. All right. Okay. So the prevalence of other disordered eating behaviors is very much elevated. What we see is we have a high rates of binge eating disorders present in this population, and a lot of vomiting, laxative use, and diuretics. The readiness of clients for weight loss therapy or even bariatric surgery is amongst different variables variables influenced by whether they have an eating disorder. So first, we must differentiate between disordered eating and eating disorders because these are quite complex. So if anybody amongst you are interested in upskilling or skilling yourselves professionally, then as I said, I provide these trainings. in the online. They're available online, and I train all healthcare professionals. This is not specific just for counselors or psychologists. I have many actually medical doctors who actually specialized in this field, who are interested in the psychological aspect or counseling aspect, to include this either themselves to upskill professionally so that they gain more knowledge and understanding, but also to consider maybe recruiting or having another additional member of the team, a psychologist specialized in obesity therapy treatment, to be part of their multidisciplinary team. It's important to assume, not to assume, of course, that all clients have eating disorders. That means not everyone who has obesity has an eating disorder. So it's important to be aware of this. A person generally with an eating disorder will tend to have a catastrophic reactions to what we call lapses. It's a form of relapse. A lapse event means kind of a massive escalation of unwanted behavior. So if your patients present with such a reaction when in your assessments, then this could be an indicator of possible eating disorders. Those patients with obesity, with eating disorders, can potentially engage in weight. I mean, we can consider them for kind of a weight loss therapy, but only after they have developed a healthy relationship with food. That means we don't think about weight loss. We don't talk about consider bariatric surgery without first treating the eating disorder. Because attempting at any form of weight loss or even surgery with a client that has an active eating disorder or a binge eating disorder can lead to dropout. It can lead to negative outcomes. So this is really something we want to be very aware of. So here as specialists, if we are to have a successful outcome of patients who choose to undergo bariatric surgery and who have passed the criteria for suitability, we want to make sure that we want to highlight that all the different risks and complications. I'm sure that you all explain these different risks, complications upon seeing your patients, and before actually going through this process, we want to take this a little bit further and really include the psychological assessment of the person before undergoing before taking the decision to undergo the surgery. We must all know that the bariatric solution does not come without risks nor complications. We know in the UK alone, we know that the number of cases with obesity is rising. We know that the gold standard surgery is sleeve gastrectomy, as it's the least invasive and easier to perform. We need to assess, therefore, the suitability and also assess psychological status and other comorbidities. Many patients have experienced stigmatization. This is a big area. Stigmatization very often comes from doctors themselves, leading to reluctance of people who have obesity to actually seek treatment. I mean, there's a lot of shame associated with this condition. So we really have to understand the patient as a whole who comes in, and not just think, okay, I'm going to perform bariatric surgery. That means we really need to understand the patient who's coming in the room, and we have to address these issues from the very beginning, because stigma comes in so many forms. One example is assuming a very common assumption is that people of larger size are lazy, and that they need to do more effort, or they need to eat less. This is a very common myth, and it's also very stigmatizing. Medical risks and conditions such as diabetes, prediabetes, high insulin levels, and low testosterone, thyroid issues are all risks that need to be carefully evaluated. One more thing I would like to say about stigma is that we know that patients who are coming to see us in the room are all coming with some form of stigma. Stigma because of what's happened to them in the environment, because we live in an obesogenic type society. So they're coming with a lot of carrying a lot of self-stigma, as well as indirectly stigmatized by healthcare professionals. We have to say one thing. I don't know if you are aware of this, but the moment that we kind of agree that a person must lose weight, we are already stigmatizing the individual, because we're saying that they are too overweight. Now I'm opening a big topic by making this statement, but this could be left maybe for another time. But stigma is a big issue, and it does warrant some careful attention and careful discussion. So a lot of the patients will about a quarter will present with a history of major depression. 3/4 will have experienced suicidal thoughts, and over 1 in 4 will have a diagnosable binge eating disorder. 1 in 4. So high levels there will be high levels of mental distress. This being said, not everybody who has obesity has a mental health condition, and not everybody who has obesity has an eating disorder. So, so these are all the domains of treatment that the patient is coming in to the clinic with, and this is why these are important considerations. And as psychologist experts in the field, we understand the client in the room, so we know what's going on with them without even them saying anything to us. So we must address all of these different elements within the assessment. This is not even before the person has chosen to go for bariatric surgery. That means the person is coming and deciding that they've exhausted all different approaches before, that we've really assessed their actual motivation to change. Because if their motivation to change is based just on the wrong motivation, then it will also affect the outcome. So we have to address stigma, we have to address personal physiology, we have to address lifestyle, we have to address nutrition, their lifestyle choices, we have to address their beliefs, the meaning they have attached to food, and their childhood experiences, different relationships, their body image. There's so many elements, as I'm sure you know. So the treatment is kind of systemic. Systemic meaning that we really need to be covering everything in many ways. And this is there's a lot of new findings being done in health psychology that really focuses on well-being. And how we can actually improve a person's well-being and not focus on weight goals. And that is something that's also very important. There's a polite word of caution here. I want to just highlight that there's a bidirectional relationship between obesity and poor mental health. Meaning, so we don't want to make assumptions that, like I said earlier, that everybody with obesity has a mental health condition, because having a mental health condition could actually cause obesity, but also obesity could also might cause a person to develop mental health. For example, because of stigmatization, that can lead to high stress, it can lead to inflammation, it can lead to anxiety. Mental health issues can contribute to inflammation. It can contribute to overeating as a coping mechanism. There's also factors related to genes for depression and as well as high BMI. So there's a correlation there. Prenatal stress can affect brain development and impact emotions and metabolism. There's a systemic inflammation caused by fat cells, can contribute to depressive symptoms. And we need to, the impact of weight on mental health is generally small, but stigmatization can worsen the effect. So assessing clients' readiness to change is really important. So what is the ideal bariatric patient? Again, what is their motivation?
Hello?
I think maybe internet problem from Dr. Jeremy's side.
It could be because, yeah. Okay.
Yes, I will connect with him and check because internet in Lebanon is not the best. So let me check with him.
Yeah, we're trying to help from here as well. Dr. Michelle, ممكن can you check with Dr. Jeremy if there is anything we can help with?
Yes, I'm actually calling him right now.
So basically for the delegates also, I think Mr. Ahmed, he can tell us. I think most of the lectures being recorded. Whenever you want to review in the YouTube channel for Education Plus, you can just review the details of lecture and also go for any presentation interested to read more details or the slides. So you can be back to the YouTube. I think like
yes,
that.
Dr. Asad, this will be this link to the YouTube recordings will be sent along with the attendance certificate and
Yes.
CME certificate. Okay, at that time.
Okay. After the end of the conference. Thank you.
Yes, 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 and they can view all the recorded sessions, presentations.
Okay, we'll wait for Dr. Jeremy to join back.
It's good to know, Dr. Asad, that we had like during the day, even now we still have 104 attendees, delegates. During the day, we had like 130 plus delegates. So we are happy that our attendees are still with us till this time. And I think the lectures this morning were very interesting, versatile, and from different topics and speakers around the world.
Yeah, thank you all of you, and thank you for Dr. Iman, Ahmed and his team also, Education Plus, for Dr. Ghazi, all
Thank you
the
very much,
delegates.
Yeah, thank you, Dr. Ghazi, for your attendance. It's always
يا
a
والله مشكورة.
add value, ما شاء الله عليك.
خدمتين لازم تخدمين جماعة مع لبنان عشان بس حبا يعني.
يعني اليوم جبنا لكم 3 from Lebanon at different places.
والله كويس يعني.
ربيع ماضي he's in Dubai ودكتور ميشيل ودكتور جيريمي ف this time
لو قال لنا احنا نروح لبنان مستعدين نسمعهم.
ان شاء الله ان شاء الله.
الله يعافيك مشكورة.
تسلم يا دكتور.
خلاص.
We have one question. Are we allowed to share the link to YouTube or live stream for non-participants in the conference, Ahmed?
Yes.
They can? Okay.
For YouTube, yes, YouTube they can share, but other link been sent for them to register is only specific for them. So they
Yes.
cannot share it. But for YouTube, yes, of course, because it will be published. I mean, it will be for public also. Later, it will be also active.
Yeah, correct. Connect.
Yes,
Hello.
okay, back. Okay.
Good to have you back. يلا. دكتور جيريمي يلا no problem.
My luck today.
هو ما بيأثر يلا first time. It's okay. يلا أهلا.
Okay, thank you. Okay, so I was here talking about the ideal patient, and we want to assess the reasons for weight loss. We know, for example, some studies that have been done. One of them by the National Weight Loss Registry in the US, where they carried out this with many patients who had obesity. In here, I'm not referring to people who underwent bariatric surgery. It's just in general those who had obesity, who followed this specific program, where weight goal was not the focus of the approach. Long term, these patients had much more successful outcomes. They all displayed higher well-being, better lifestyles, and the symptom of that was actually weight loss. So what we learned from this is, as long as weight loss is the goal, it interferes long-term with improved outcome by causing a great deal of stress, especially when these patients are not successful in their being sustainable. So this means we really need to relook the entire approach that we have to better serve the patient who would like to lose weight, and that we want to honor their desire to lose weight because of well-being, or because of pain, or because of lifestyle, and not because of some other motivation that might not necessarily be the right one. So very quickly, I'm going to overview here the 3 steps that needs consideration. And there is a special counseling course that is being offered through the National Center of Eating Disorders. This is a scale-up course. It's a 2-day course for anyone in the field who would like to develop improved counseling skills for bariatric patients. So the focus is really on health psychology, and health psychology is really about positive change for life. It's not just for physical health, but for positive change overall in one's psychological well-being. So I'll go through stage 1. So we would like to foster change without stress, so that the person shows readiness and willingness to change. We will have to address the mindset for preparation. We will have to address the psychological challenges, like management of anxiety, identifying their relationship with food, their food meaning, any unhelpful habits they have, the unhelpful coping mechanisms that they have. We know that people of larger size will very often reward themselves with food as a way to cope with their emotions. So this is something that we also need to address. We have to, in the first stage, also look at pre-surgery nutrition requirements, how to prepare for surgery, how to gain the help and the support of family and friends. As I said, directly as a result of overcompensation the people of larger bodies is likely to suffer from higher appetite drives and responsiveness to eating cues due to conditioning and reward value of eating together with kind of a less or a weakened inhibitory capabilities. So we must handle all of this with care. And of course, planning for post-surgery as well is part of the stage 1. Stage 2, so post-surgery stage, this is where we have to be working on aspects of managing expectations and managing challenges, how to handle weight change. Many find themselves in a different body, and this can have various effects on different people. So they respond differently. It will present with psychological challenges, emotions, identity, stigma as well. So we need to teach them how to deal with plateau. That means when they find themselves in not noticing any progress, how to deal with malnourishment, because these surgeries will also impact their, how their bodies, their physiology is operating, and how they are eating and their choices. We need to also address aspects of emotions such as loss, such as grief as well, anxiety, low mood, body dysmorphia, as well as the effects of any prior eating disorders. So, as I said before, if there's a presentation of eating disorders, we will not have accepted to have the surgery or have the patient undergo the surgery without having that under control. So stage 2, so the effects of when I say the effects of eating disorders, is there any reemergence of the eating disorder? This is something we need to also assess and be aware of. How to develop healthy relationship with food, and also assess nutritional needs for the bariatric patient as a result of the changes in the digestion, changes in absorption, and altered physiology. As well as how to enhance physical recovery in a motivational manner. So this is part of stage 2, and the last stage is lifelong maintenance. This is really about creating the right mindset for lifelong maintenance, working psychologically on creating new comfort zones, finding new ways to deal with stress, adjusting to a new identity, rebuilding their self-esteem, assessing various aspects of nutritional needs as well, and how to support, how to learn skills for improved emotional resilience, for improved well-being, and those would be like the 3 stages. I'm curious to know if this is something that you automatically do with your patients, for all the medical doctors here and surgeons who do this practice. Do you have psychologists as part of your teams? And is what I've been sharing today something that you are very familiar with? Thank you. And I'm giving the next training on the essential aspects of obesity and the latest psychological interventions for that on the 20th of June. For any of you who are interested, this is a virtual meeting training with continued professional development points. So it's CPD approved. And I'm also a member of the Association for the Study of Obesity. So thank you very much.
Thank you, Mr. Alford, Dr. Alford, and Naufal. Dr. Naufal, really appreciated your participation and interesting topic, especially at the end of the day. And we wish also to see you tomorrow in the third day of the IMDO conference tomorrow, 9 o'clock in Bahrain time. Looking forward to see all of you. Thank you and good day. Bye-bye.
Thank you very much, Doctor. Thank you very much. Thank you, and thank you for having us.
Thank you, Dr. Jeremy.
Thank you, Dr. Iman. Thank you. Thank you.